We are live. Dr. Abhinay, we are live. We can start.
Yes, okay. So is my screen visible?
Yes, ma'am. All good.
Okay. Good evening, everyone. On behalf of All India Ophthalmological Society, I, Dr. Abhinay Valliyappan, warmly welcome you to the 16th episode of GuruSangam webinar series, a platform to enrich and expand the knowledge and skill set of postgraduate students and helping them excel. Every episode of GuruSangam, we bring together passionate teachers from around our country to discuss regarding a topic of their choice and expertise. Every lecture is detailed and in depth. This, coupled with the clinical expertise and vast experiences from our expert panel, gives the PGs an excellent overview of the specialty. In today's episode, we will be focusing on my favorite specialty, strabismus, which is, I'm sure many of us will agree, underrated during postgraduate teaching. Hope this session turns out to be a great experience for all. So before we begin, I would like to acknowledge and thank our chairman, Dr. Sama Basa, President AIOS, for his
Ma'am,
constant...
if you can please move the slides are not moving.
Okay. Before we begin, I would like to acknowledge and thank our chairman, Dr. Sama Basa, President AIOS, for his constant motivation behind this program, and the program directors, Dr. Santosh Honavar and Dr. Manoj Mathur, for coordinating and tailoring this beautiful program with their untiring efforts. Thank you so much. Without further ado, I warmly welcome the speakers, panelists, and audience who have logged in and take this opportunity to invite and introduce the faculty for the expert panel. This evening, we are privileged to have the distinguished panel of experts, each of them with immense clinical experience and expertise in this field of strabismus. First, we have Dr. Ankur Sinha, a renowned cataract, glaucoma, and strabismus surgeon from Max Vision Eye Care Center, Jaipur. Welcome, sir. Next, we have Dr. Deepti Joshi, pediatric...
Ma'am, slides are not moving. Please.
Next, we have Dr. Deepti Joshi, pediatric ophthalmologist and SQUINT specialist from Joshi Eye Hospital, Hubli, Karnataka. Welcome, ma'am. We have Dr. Kavita Venkatachalam, senior consultant at Shankara Eye Hospital, Shimoga. Welcome, ma'am. Dr. Manjushri Bate, who is a renowned cataract and strabismus surgeon and also practices pediatric ophthalmology, SQUINT and neuro-ophthalmology at LV Prasad Eye Institute, Hyderabad. Welcome, ma'am. Dr. Shubhangi Bhave, a renowned pediatric and comprehensive ophthalmologist since last 40 years, practicing currently at Drishti Eye Hospital, Nagpur. Welcome, ma'am. In the expert panel, we also have Dr. Simi Zaka Urab, Professor, Department of Ophthalmology at AMU Institute of Ophthalmology, Aligarh. Welcome, ma'am. So we will be having 4 speakers who will be discussing on topics of their choice for 30 minutes, followed by panel discussion. Without further ado, I would like to continue with the first speaker's introduction. So at first, we have Dr. Siddharth Agarwal, who is in charge of the strabismus services at King George's Medical University, Lucknow. He's done his medical education from KGMU, Lucknow, and also Ratan Tata Fellowship from Shankar Netralaya, Chennai. He has also done observerships at Singapore National Eye Center, Weill Cornell University, New York, and Columbia University, New York. He's received various international travel grants and he's worked on 2 extramurally funded projects. He has varied publication skill set, 75 peer-reviewed publications, 1 patent, and he's authored 2 PG textbooks on strabismus and pediatric cataracts published by Springer, Singapore. He's also been the recipient of Young Investigator Gold Medal by KGMU University and several other research awards. He's won the Best of IGO Award by AIOS, and he's conducted over 200 pediatric cataract and 100 strabismus surgeries annually. Welcome, sir. We'd like you to share your screen. He will be discussing on understanding the basics in strabismus.
Hi, good evening. Good evening. Greetings from Lucknow. Strabismus is a frequently avoided topic by the postgraduates. The purpose here today is to provide a basic overview of the topic and touch upon the important concepts essential for understanding this slightly difficult subject. I hope to be able to do some groundwork for the deeper understanding of strabismus in the subsequent lectures. My presentation has been divided into 3 parts. The first part is consists of the basic theory required for understanding strabismus. The second part is related to the understanding and the basics of examination. And the third part has some interesting clinical concepts which will make the understanding of management of strabismus easier. The students should be able to answer these concepts, should be able to understand these concepts by the end of this lecture. What is strabismus? How do the eyes remain aligned? The ocular movements of the eyes, the sensory and the motor adaptations following strabismus, and they should be able to differentiate between comitant and incomitant deviations. They should know the basics of examination and the basics of classification and management of comitant deviations. I've included only comitant deviations because this is by far the commonest type of strabismus that we see in clinical practice. Now, what is strabismus? It is the inability of the two eyes to simultaneously direct their fovea to a common object of regard, occasionally or always. Now, the lines LF and FR are the visual axes of the two eyes. And if a person is able to direct their visual axis to a common object of regard all the time, then the patient has orthotropia. However, if at some times this is not possible, that the visual axis of one of the eyes is unable to be focused, then we call it heterotropia or manifest strabismus. The students must note that we have not included visual acuity or the ability to focus in the definition. The reason being that strabismus may occur in a non-seeing eye also. With regards to heterotropia, if the eyes are convergent, we call it esotropia. If they are divergent, we call it exotropia. Similarly, if one eye is up, we call it hypertropia, and if one eye is down, we call it hypertropia. Now, the next important thing to understand is that what keeps the eyes aligned. Both the eyes, the extraocular muscles, and the nervous system function together as a sensory motor unit to keep the eyes aligned. The extraocular muscles and the nerves supplying them are the motor unit, and the ability to enjoy binocular vision consists of the sensory unit. Both these systems work in unison and are mutually reinforcing, meaning thereby, if there is some fault in one of the systems, the other system takes over and tries to compensate for it. And when both the systems get overwhelmed, strabismus occurs.
तो ऑडियो है
Am I audible?
Yes,
Yeah, doctor,
yes,
you're audible.
Yeah.
You're audible.
yes, sir,
Yeah.
yes, sir. You can
Oh,
proceed.
there was some interruption. I thought, yeah. So now moving forward, now the students must understand the ocular movements. Now, uniocular ocular movements are called ductions, as in abduction and adduction. We strabismologists are very particular about using the word AB and AD so as to remove any ambiguity when it comes to pronunciation. Now, if this right eye is looking towards the right side, then it is abduction. And if the right eye is looking inwards, it is adduction. The binocular movements can be termed versions. Versions would be when the eye is, let us suppose, looking, both the eyes are looking up, then we call it elevation. When both the eyes are looking towards the right, we call it dextroversion. And when the eyes are looking to the left, we call it levoversion. Vergences are disconjugate movements of the eye to maintain fusion, as in convergence and divergence. Now, if the students can understand the origin and the insertion of the extraocular muscles and the axis along which the eye moves, they would not need to mug up the actions of the extraocular muscles as they usually do. They would be able to recall it just by understanding the origin, the insertion, and the axis of the eye. Then the next important terminologies are agonist and antagonist. Agonist is when the eye is being moved in a particular direction, that muscle is an agonist. Now, for example, for the right eye to be moved to inwards, the agonist muscle would be the medial rectus. And, for the left eye to be moved inward, the agonist muscle would be medial rectus, and its antagonist would be the lateral rectus muscle. Two muscles of the same eye which are responsible for the particular movement are called synergists. Now, for elevation, the synergist would be superior rectus and the inferior oblique muscle, as both the muscles are moving to elevate the eye. And when we consider one muscle in each the eye responsible for a particular gaze, let us suppose in this photograph, when the patient is looking to the right and up, as in dextro elevation, the right superior rectus and the left inferior oblique is contracting. These two muscles are called the yoke muscles. Note the spelling of yoke, which is Y-O-K-E and not Y-O-L-K as postgraduates commonly misspell it. It would be interesting to know that the word yoke comes from this wooden crossbar which is placed over the cattle when they plow the field. Now, it ensures that both the cattle move together in tandem, just like the two muscles, the yoke muscles, which move in tandem to move the eyes together. You must have understood now that the action and the movements of both the eyes is a finely titrated mechanism, and there are two laws which govern it. First is the Herring's law of equal innervation. This says that whenever the eye moves in a particular direction, both the eyes remove equal stimulus to a particular muscle to contract. Now, again, for this example of dextro elevation, the right superior rectus and the left inferior oblique receive an equal stimulus to contract according to this law. This is the Herring's law of equal innervation. The Sherrington's law of reciprocal innervation states that whenever a muscle contracts, its antagonist receives an equal and opposite relaxation impulse. Now, if the right lateral rectus contracts, the right medial rectus will receive an equal impulse to relax, enabling the movement of the eye to the right-hand side for the right eye. This is the Sherrington's law of reciprocal innervation. Now, once we have understood the motor mechanism, let us understand a few concepts about the sensory mechanisms responsible for keeping the eyes aligned. Binocular single vision is the single most important sensory mechanism driving the motor ocular alignment. Like fovea, other points of the retina of one eye also correspond to the retinal points of the other eye. Image falling on the corresponding retinal points is perceived as single, and if it falls on the non-corresponding or the disparate points, the image is perceived as double or diplopia, and this provides a feedback to keep the eyes straight. Now let us see the same photograph which we had seen earlier. Now, if the image of the object in consideration, F, is falling on the fovea of both the eyes, the image will be perceived as single. Now, similarly, if this image was falling on the temporal retina of the left eye and the nasal retina of the right eye, the corresponding retinal points, it would again be perceived as single. However, if the image falls on one fovea and one non-corresponding retinal point, the image would be perceived as double. Now, nasal retina has temporal projection. Now, so if the image was falling at this point, it would be perceived outward, and it would be seen as double. Now, this double image is providing a feedback to the brain to align the eye and make the eye straight. This is the motor fusion mechanism which comes into play. The second level of binocular vision is fusion, which allows the eyes to fuse two slightly dissimilar images into a single image at cortical level. And the highest grade of binocularity made possible by the horizontal separation of the two eyes, causing the images to be slightly dissimilar and be fused at the cortical level, is stereopsis. Now consider this example where I have placed some similar colored pencils in a jar at a particular distance, and the two eyes are looking at it. Now the left eye is getting a better left-hand side perspective of the object, and the right eye is getting a better right-hand side perspective. What I mean to say is that the two images being perceived by the eye are slightly dissimilar. And this dissimilarity is fused at the cortical level to form a single three-dimensional image. This three-dimensional image will enable the observer to identify which pencil is placed more anteriorly compared to the one placed posteriorly. Now, a question here for the audience is that why have I used similar colored pencils in this jar? What would happen if I had used different colored pencils? If you can answer this question in the comment box, I would be happy to discuss it further later. Now, you must remember that for development of binocular vision, it is important that the motor alignment is ensured during the growing age, that is below 6 years of age. Below 6 years of age, if the eyes develop heterotropia or strabismus, this motor alignment would not develop. The sensory development would not occur, and the patient may eventually have subnormal binocularity even if we align the eyes later. Now, what are the adaptations which occur in response to heterotropia or obvious strabismus? The commonest adaptation to occur in response to strabismus is anomalous head posture. Anomalous head posture, as I have told you in the previous slide, may be adopted to overcome diplopia. AHP has three components: the face turn, the head tilt, and the chin elevation or depression. Now, diplopia occurs when the one eye fovea is getting stimulated and the other eye non-foveal point is getting stimulated. In these diagrams, notice that the dotted line is the foveal projection of the squinting eye. Now, if the fovea of the left eye is getting stimulated in this example, and a point temporal to the fovea is getting stimulated by the same object in the eye which is having exotropia, you will notice that the temporal retina having nasal projection, the image is getting projected on the other side, as in for the right eye, the image is getting projected on the left-hand side. And this is what we call crossed diplopia. And the reverse would occur in esotropia when we call it uncrossed. Sensory mechanisms occur in response to strabismus, and they usually occur in younger children. The commoner adaptations are suppression and amblyopia. Suppression is active central inhibition of the image from the eye when both the eyes are open. And prolonged monocular suppression in childhood may eventually lead to amblyopia, which is where the subnormal vision persists even when the better eye is closed. Another very interesting sensory adaptation is abnormal retinal correspondence. This occurs in long-standing, early onset, small angle, constant deviations, and more frequently in esotropia, where now you can have a look at this example. Now, if the non-foveal point, which is slightly nasal to the fovea, is getting constantly stimulated by the same object which is being seen by the fovea of the eye, which is looking straight, that is the non-squinting eye, this extrafoveal point may over a period of time develop correspondence to the fovea of the eye which is looking straight. And this enables a subnormal level of binocular vision. This is a nature's way to overcome strabismus, and this is better than a constant strabismus with no binocularity. This ensures subnormal binocular vision for most functional occupations, even in the presence of a small angle strabismus. Now, with this understanding, the students should be able to differentiate between the two common types of strabismus that we usually see. The first group is the comitant group, and the second group is the paralytic or the restrictive group. In the comitant group, the onset is insidious and usually in childhood, whereas in the paralytic group, it is usually a recent onset and it is associated with diplopia. The hallmark of paralytic and restrictive strabismus, also known as concomitant strabismus, is motility limitation, secondary deviation being greater than the primary deviation, which I'll just explain, and the presence of head posture. Now you see in this photograph, in the upper photograph, notice that the patient is having a esotropia of the right eye. This patient has right lateral rectus paresis. The left eye is fixing. Now, if we occlude the left eye and force the right eye to take fixation, we notice a larger deviation in the left eye. Now, the deviation which is occurring in the squinting eye is known as the primary deviation, or the diseased eye is known as the primary deviation. And the deviation which is occurring in the normal eye is known as the secondary deviation. The patient has right lateral rectus paresis, so the deviation in the right eye is primary, and the deviation in the squinting eye is secondary. And notice that the secondary deviation is larger than the primary deviation. This is the hallmark for all paralytic and restrictive deviations. With this, we come to the second part of the presentation, which deals with examination. As you can see, fortunately for us strabismologists, we don't require too much of expensive equipment for conducting our examination. They are quite basic equipments available in almost every OPD. The examination can be divided into three parts, with first part being the most important and often neglected: vision and refraction. The moment the students see a patient with strabismus, they jump on to do the cover test. No, please remember that performing an appropriate vision and refraction is the first step of examination of any type of strabismus. The second step is motor examination, and the third step is sensory examination. We'll be covering a little bit about them in the subsequent slides. Age-appropriate methods should be used to assess the vision. Small children may require equipment like optokinetic drums, teller acuity chart, and the preschool children may do well by explaining them the E-chart and trying to document the vision patiently. Refraction should be performed under adequate cycloplegia according to the age and the race of the child. It makes a lot of sense to observe the pupillary reflex or the Bruckner's reflex, more so when you notice that the Bruckner's reflex is asymmetrical. Note here that you see a superior crescent, which frequently occurs in patients with hypermetropia. You must observe the deviation under cycloplegia as it takes care of the accommodative component of the deviation. Retina examination and fixation charting should not be missed. And should you suspect amblyopia, a detailed workup to rule out other causes, and then finally documenting the amount of amblyopia is essential. The motor examination, I told you that the head posture has three components. Carefully look for them and document them. The Hirschberg's test gives you an idea about the amount of deviation on torchlight, and we confirm it with the cover and the cover uncover test. While performing the cover test, the head posture of the patient should be eliminated, and the patient should be asked to look at a specific target. For near, the target may be placed even on the frame of the examiner, as is shown here in this photograph. The prism cover test is used to document the amount of deviation. I'll be dealing with the cover uncover test in the subsequent slides to explain them, because they are the backbone of strabismus examination. Subjective tests like Hess charting help you to document the subjective responses of the patients in an objective manner. These charts give you a number telling you about the amount of deviation, and they are extremely useful in documenting the deviation and also in follow-ups, where you can notice whether the deviation is increasing or decreasing or remaining constant. The eyes are dissociated with red-green glasses, and the head posture should be eliminated while performing these tests. The ocular movement should be carefully documented, and I find taking photographs a very useful method to document the limitation in ocular movement and subsequently their change over time. Once versions have been documented, do not forget to check for ductions. Very often you may find a limited version, however, the duction may be normal. And finally, look for the convergence and the divergence movements. Now, there are a few videos here to show you the cover test. Note here that when we cover the fixing eye, the left eye moves in to take fixation, and the repeat occurs when we fix the left eye. And alternately, you notice that the patient is able to maintain fixation with the either eye. This tells you that the patient is having an alternating esotropia, and the vision is almost equal in both the eyes because the patient is able to maintain fixation with either eye. Now, in the next video, notice that when I cover the fixing eye, the right eye moves out to take fixation. So this patient has a right esotropia. Also notice that the right eye is unable to maintain fixation. That is, the moment I remove cover from the left eye, the right eye moves in again. This tells me that this patient has right esotropia, and the vision in the right eye is poorer than in the left eye. Now, this is a similar video where the patient has right esotropia. However, here we try to neutralize the deviation with the prism bar. We place base out prisms in front of the right eye, and we force it to take fixation by occluding the fixing eye. Gradually, we increase the amount of the prism till we notice that there is no movement of the right eye and the patient is fixing through the prism, or there is reversal of the movement in the opposite direction. This tells us the amount of deviation in the right eye. Now, another interesting video. Notice here that when I'm occluding either eye, the eye which is uncovered, which is not being covered, is not showing any movement. See, when I'm occluding the right eye, the left eye doesn't move. And when I occlude the left eye, the right eye doesn't move. However, movement is being noticed when I uncover either of the eye. The moment I uncover the left eye, it moves from out to in. The moment I uncover the right eye, it moves from out to in. Notice again, on covering, there is no movement. However, on uncovering, the movement is from out to in. So, this patient has exophoria. There is no deviation when both eyes are open. However, when we cover either of the eye, it moves outwards under cover. So, we call this deviation exophoria. Now, in this video is for the audience to answer in the text box, in the comments box, to tell me what am I showing. A hint here that it is a combination of the two conditions that we have discussed in the earlier videos. Notice what is being shown. I'll run the video once again before we move on to the next slide. Now, sensory examination of the patient consists of assessing the diplopia. And for the sensory examination, remember that the eyes have to be dissociated and the patient response has to be noted. Diplopia chart, when performed properly, gives you a lot of useful information, and it can be used to quantify the deviation and at the same time to see the follow-ups and the change in the deviation. Worth 4 dot test, again, it gives you an idea of the binocular status of the patient, and stereopsis can be quantified by using tests like the random dot stereograms. Now, with this, we come to the final part of the presentation, which deals with the clinical part of comitant strabismus. Now, this is a basic classification of horizontal comitant deviations, which the PGs should remember. Esotropia can be classified into accommodative and non-accommodative types, depending on whether the deviation is larger for near or it is constant. That is, it is same for distance and for near. Accommodative esotropia is associated with deviation larger for near. So accommodative esotropia can be subdivided into refractive and the non-refractive types. Refractive esotropia, refractive accommodative esotropia is one which gets corrected by use of hypermetropic glasses, whereas in the non-accommodative, in the non-refractive accommodative esotropia, hypermetropia is not playing such a significant role, as is the abnormality of the accommodative convergence by accommodation ratio. It is usually abnormally higher. So these children would require bifocal glasses. In the non-accommodative esotropia, essential infantile is by far the commonest variant. And we are also seeing an increased number of acute onset late esotropia, which in the post-pandemic time is being attributed to excessive digital devices and excessive near work. The sensory type is associated with poor vision in one eye, and then there are the less frequent types to complete the list. Exophoria, intermittent exotropia, and constant exotropia are part of the same continuum with progressively worsening fusional reserves. They are the same entity. And the exotropia is differentiated on basis of whether the deviation is larger for near, larger for distance, or it is remaining the same both for distance and near. Please remember that esotropia and exotropia are not reverse of each other, but totally different etiologies and have a totally different pathogenesis, which will become apparent as we discuss the clinical features in the next slide. The essential infantile esotropia I'm mentioning here because it's the commonest type. It has early presentation, stable large angle, and it is associated with amblyopia. The other common type of esotropia is the accommodative type, which I told you earlier, and it is associated with a larger angle for near compared to distance. Now note here that exotropia presents later and esotropia has an early presentation. Intermittency and variability are associated with exotropia, whereas infantile esotropia by and large has a stable angle. Good binocularity is associated with exotropia, and amblyopia is a feature of infantile esotropia. Exotropia is usually progressive. Now, just 2 slides about the management. I would reiterate here that refraction, prescription of appropriate glasses, and giving adequate time for adaptation to occur is by far the most important requirement for management of any type of strabismus. Most patients would do well with an adequately prescribed glass, and that is all what is required for management of many types of strabismus. Amblyopia treatment, should amblyopia occur, amblyopia treatment should be done aggressively, and patching remains the gold standard. Orthoptics do have a role in management of certain types of strabismus, and they help in delaying the surgery, as in intermittent exotropia. And surgery, once indicated for a particular type of deviation, should not be delayed. Now, students often get confused about what surgery to do, how much to do. They have been answered in this slide. So, resection surgery of single eye is by far the commonest type of surgery done, for the simple reason that it is easier to convince the patient for a single eye surgery. However, we do bilateral surgery as bimedial recession in infantile esotropia and bilateral lateral rectus recession in pure divergence excess type of exotropia. How much surgery should be done? Remember that recession of the medial rectus is the most effective surgery, and resection of the medial rectus is the least effective surgery. In between are the recession of the lateral rectus muscle and the RES, resection of the lateral rectus muscle. And by a simple nomogram here, 5, 3, 4, 2, and 1, you will be able to remember how much correction you will achieve by performing a millimeter of surgery for each of these muscles. So you can get up to 25 prism diopters of correction by performing 5 millimeters medial rectus recession. And that is how you can calculate the dosage required for a particular type of deviation. Here you would like to take the lower dosage for conditions like surgery in an adult, surgery in a smaller deviation, or in presence of poor binocularity. Now, which eye should you operate? In presence of good vision and you expect good binocularity to return post-operatively, you perform bilateral surgery or you perform surgery in the eye with better vision. However, when you are operating in a patient with poor binocular potential, wherein you don't expect good binocularity post-operatively, so it becomes more of a cosmetic surgery, there you like to operate on the eye with worse vision. And in presence of incompetence, you like to operate on the eye with larger deviation. Finally, the management goals. The ideal goal that you would achieve after successful management of strabismus is restoration of normal vision and normal stereopsis in all gazes. However, this is frequently not possible. So we target the functional gazes, that is the primary gaze and the down gaze. And as far as the motor outcome is concerned, orthotropia is ideal, and a small residual esotropia is the second best outcome for most types of deviation. There is no summary slide in my presentation, as I felt that this presentation itself is a summary of all that we expect our postgraduates to know. If you can understand these concepts, you are likely to do well in a strabismus case. You might need to go through this presentation once again, and I would be happy to clarify any doubts should they occur when you read the presentation. All the best. Thank you.
Thank you so much. Thank you so much. That was a wonderful presentation, Dr. Siddharth. Very compact, concise, and informative overview of SQUINT basics. And I would also think it's a very apt opening lecture for this series. Thank you so much, sir. With this, I would request the panel to provide their expert perspectives on this topic, including tips for the postgraduates. So I would open with Dr. Ankur Sinha, sir, please.
Yeah, I think it's a difficult topic. The basics of everything to discuss is actually very difficult. So Dr. Siddharth has done a very good job. He took care of almost everything, how to define ESO and EXO. I think I missed somewhere, I think, did he talk about pseudo-ESOs and pseudo-EXOs, which is also an important part to be understood because a lot of young children, especially infants and maybe up to the age of 2 to 3 years, people do come with pseudo-esotropias because they have a broad nasal bridge. So that's a very valid concern of patients that we have to take care of all the apprehensions they have. And also, I think it's nicely said that we need to look into the sensory part also. That is the stereopsis and the fusional things which we have. The God has given us fusion and stereopsis, which is very important part of the binocularity we have. So the testing of fusion, testing of binocularity and stereopsis is also an important perspective into the basics of strabismus. But I can understand like it's a very difficult topic to justify everything into half an hour is actually really difficult. So I congratulate Dr. Siddharth for taking care of almost everything. And so that few tips which I wanted to add to this nice presentation.
Thank you so much, sir. Dr. Deepti Joshi.
Dr. Siddharth, that videos were really wonderful. I think he said we cannot sum it up, but his PPT was so nice that I was summing up when he was actually presenting it. So for postgraduates, I think DNB, one SQUINT case is mandatory. So when it comes, I think what sir said, I would sum up what Siddharth sir said. Sensory evaluation comes first and then the motor evaluation, usually when you present in your case presentations. And number two is, he mentioned very clearly the difference between alternate cover test and cover uncover test. Most of the children, the moment case is presented, they start doing this. So please don't jump into alternate cover test. It's the cover uncover test when you see the tropias, and alternate cover test only when you see phorias or when there is an intermittent squint, which is very less kept as an examination case. And extraocular movements, which Dr. Siddharth has already mentioned, you have to represent both as ductions and versions, which is very important, one plus and one cross. That's the way usually it is represented. So please mention both the EOMS in your examination sheet. And last, the moment we ask, how would you manage this case? The first thing usually PGs tell is surgery. No, amblyopia and refraction comes first, only then go into the surgical part. And that's how Dr. Siddharth also presented it in his presentation. So overall, kudos to you, Dr. Siddharth. That was a wonderful presentation. And with this, I would like to sum up my few tips for the postgraduates for this presentation.
Thank you, ma'am. Thank you so much. Dr. Kavita Venkatachalam, ma'am. Any tips?
Yeah, I want to congratulate at the outset Dr. Siddharth, and also for the book that he has written on strabismus for everyone. The common mistakes that we tend to do, which I have observed, is to understand how to perform extraocular movements. Basically, the way we sit at the level of the patient and where you keep the object and test. Invariably, what I have seen is that when we are having the object in front in primary position, the distance is okay. But then eventually when at the gazes, the object tends to go closer to the patient, and then, the way we interpret the ocular movement or any limitation is they fail to understand that. So the object and the distance from the patient is very important. And all the 9 gazes, the way we examine, is a common mistake done by the students. So maintain the level of the eye and the examiner, both patient and examiner, the level should be same, and the distance of the object from the patient. And it's especially important to understand the patterns. So once we detect the pattern, then we know that management becomes easier. And also to understand the presence of nystagmus understanding the vision in each eye is very important, especially in younger children. That is what parents will want to know, whether the child is having good vision or not. And most important is counseling. So we have to train ourselves or train our students as well how to talk to the parents and explain to them what exactly the child is having in each eye. And I think this is what I wanted to tell, where our students are missing upon.
Yes, ma'am. That's true. Thank you so much. Dr. Manjushri Bhate, ma'am. Anything to add? Okay. I think I'm not able to hear. So I'll, Dr. Shubhangi Bhave, ma'am.
Yeah, that was a wonderful presentation, Dr. Siddharth. You comprehensively covered the examination. The vision assessment in a kid is very important, especially in a small kid. And I just like to emphasize that we don't need to have many fancy tests in order to assess the vision, especially when the child is presented with a constant squint in one eye. Even if we cannot make him read on this Snellen's, one knows that there is a reduced vision in that eye, be it because of amblyopia, be it because of any other things. And the examination to that point is of greatest importance. So many of patients have presented to us with retinal detachment or with tumors in the eye with the squint as the first presentation. And so the visual behavior of the child is one thing which we should know. And secondly, after doing the examination, as Dr. Kavita said, that counseling is very important, because most patients believe, parents believe that surgery is done, the thing is cured. So I always tell the parents of the patients that surgery is the beginning of the treatment, not the end of the treatment. So the parents should be aware that the sensory process behind the strabismus and what is involved in the treatment of strabismus. It is not a one-time thing. It is to go on for many years together.
Thank you so much, ma'am. Thank you. That's truly. Next, Dr. Simi. Professor Simi, any points to add, ma'am?
Muted. She's muted.
First of all, I'd like to congratulate Dr. Siddharth. You have covered this difficult topic very comprehensively. One thing which I have seen, a mistake which the postgraduate usually do, is that they don't correct the head posture. They, whatever the face is turned, even in cases of a non-paralytic squint. First of all, the first thing for every examination which has to be told to them repeatedly is that the head should be in an anatomical position. That's one thing. Secondly, refraction. At times, the patients, they are bothered about the squint. They'll ask, how is it possible as small child, how would the child can wear the glasses? Then again, educating the parents is very important, especially for the accommodative students, that is the treatment. You have to ensure that the child wears the treatment. Otherwise, all the rest of the things have been nicely covered. That's it.
Thank you so much, ma'am. Thank you. So without further ado, I would like to request the next speaker to be ready with the presentation. Is my screen visible?
No.
Okay. So next we have Dr. Annapurna Kumar from Arvind Eye Hospital, Pondicherry, to talk on drug testing in Horner syndrome. She's done her MBBS from St. John's Medical College, Bangalore, and MS Ophthalmology from Mysore Medical College. She's the former professor of ophthalmology and member of Medical Education Research and Ethics Committee there. She's currently a PG teacher at Arvind Eye Hospital, Pondicherry, and she's a creator of the YouTube channel AP's Ophthalmology Pearls with more than 35,000 subscribers, more than 330 videos, and more than 2 million views and daily quizzes for the past 3 years. Kudos to you, ma'am. She's also proficient in PowerPoint and provides professional medical PowerPoint design services. Over to you, ma'am.
I think you have to stop your screen sharing. Otherwise, I'm not able to share my screen.
Ma'am, I've stopped sharing it. Yes.
Okay. Visible?
Yes. Yes.
Okay. Should I start? So, good evening, everybody. And at the outset, I'd like to thank AOS for giving me this opportunity the second year in a row. And since we have a time crunch, I'll dive straight away into the topic. Now, this topic is unique because drug testing and Horner syndrome is very rarely done anywhere in the world, but is of extreme academic interest. And so residents have to know about this. And before I say anything else, I'd like you to watch the small 5-second video clip. So this is the visual that I have in mind whenever I need to remember in which condition anisocoria is greater in the dark and in which condition it's greater in the light. And when I see this, I can see it's dark, I can see horns. So anisocoria is greater in the dark in Horner syndrome. So why am I telling you this? See, this is a very volatile topic. Similar to nystagmus, you have to read it just one day before the exam. Otherwise, it's very difficult to remember. So my idea in choosing this topic today is that hopefully after today, even if you do not read this topic again before exams, you should be able to remember at least the salient points. And towards that end, I've included some visuals and some mnemonics to help you. Now, I will be talking under these headings very briefly. Each one is very brief. The sympathetic pathway, what happens at nerve terminals, what happens when you use these drugs in normal eyes, what happens when you use them in Horner eyes, and finally we come to the protocols. Now, coming to the sympathetic pathway, this is the hypothalamus, the pons. This is the seriospinal center of Budge-Waller, which is situated in the gray column of the spinal cord from C8 to T2. This is the inferior cervical ganglion at the level of C7, middle cervical ganglion at the level of C6, and superior cervical ganglion at the level of C2, which also happens to be at the level of the angle of the jaw and also the carotid bifurcation. This is the trigeminal ganglion, the first branch of which is the ophthalmic nerve, a branch of which is the nasociliary. This, of course, is the abducens nerve. So the first order neurons start in the posterolateral hypothalamus, pass through the midbrain, pons, medulla to reach the spinal cord, and to finally synapse in the cerebrospinal center of Budge-Waller. Okay. These first order neurons are also referred to as central fibers, and therefore a lesion in anywhere along this pathway is referred to as a central Horner. So you can see the central fibers here. Now, the second order neurons, okay, they obviously start in the cerebrospinal center. They emerge from the ventral rami from C8 to T1 and pass through but do not synapse in both inferior and middle cervical ganglia to ultimately reach the superior cervical ganglion where they synapse. And here are the fibers, and these, because they occur just before the superior cervical ganglion, which is the autonomic ganglion for the oculosympathetic pathway, these are referred to as preganglionic fibers. Now, the third order neuron starts in the superior cervical ganglion. Now, from here onwards, they emerge as the internal carotid nerve and plexus and are closely associated with the internal carotid, with the carotid vessels. The pseudomotor fibers, that is the fibers subserving the lower 2/3 of the face, go along with the external carotid artery. The fibers we are interested in go along with the internal carotid artery, surrounding it most of the time, enter the skull through the carotid foramen and reach the cavernous sinus, where very briefly, for a few millimeters, they are closely associated with the abducens nerve. Then they leave the fibers that are destined to supply the iris dilator, leave the abducens nerve, join the nasociliary nerve, which we just spoke about, through which they enter the orbit through the superior orbital fissure, and through its long ciliary branches supply the iris dilator. the branches destined for the mulna muscle enter the orbit surrounding the ophthalmic artery and supply the mulna muscle. Now, let's look at those fibers that are going to supply the iris dilator. So, here it's along with the abducens, leave it, join the nasociliary. Okay. And these third order neurons are also referred to as the postganglionic neuron. Now, let's see what happens at nerve terminals. Now, when we say ganglion, we are speaking about the superior cervical ganglion. This is the presynaptic terminal, the postsynaptic terminal, and the synaptic cleft. Now, whenever an action potential arrives at the presynaptic terminal, it results in calcium influx into the terminal, which results in these are vesicles containing neurotransmitter. It causes these neurotransmitter to be released into the synaptic cleft by means of exocytosis. Okay, this neurotransmitter then binds to the receptors, resulting in an action potential in the postsynaptic neuron. Okay, now a very similar thing happens at the effector junction, that is between the postsynaptic neuron and the iris dilator. Probably the only difference is that there is no well-defined synaptic cleft. It's the neurotransmitters just released into the extracellular space. Everything else is similar. What about the neurotransmitters? Between the pre- and post-ganglionic neuron, the neurotransmitter is acetylcholine. At the level of the post-ganglionic neuron, it is norepinephrine. We are concerned basically with this. Now, okay, an action potential has arrived. The neurotransmitter is released. This then acts upon the alpha-1 receptors of the iris dilator to result in mydriasis. Now, of course, the signal has to be terminated. At the level of the presynaptic terminal, the calcium goes out. That is fine. But what about the neurotransmitter? We have to get rid of the neurotransmitter. Otherwise, it will continue to act on the receptors. So the termination of the neurotransmitter action occurs in one of three ways. One, there can be a reuptake back into the presynaptic neuron. This occurs in the case of norepinephrine. Or it can undergo enzymatic degradation. All of you are familiar with acetylcholine esterase. Or it can diffuse away from the synaptic cleft. So that is what happens at nerve terminals. Now let's see what happens when we use which drugs? These three drugs. These are the classic drugs used in Horner syndrome. So first of all, cocaine. Okay. Now, here is where people forget what it does. Just watch what I have done with the cocaine. I have made it prone. Okay. Prone is your mnemonic for the action of cocaine. It prevents the reuptake of norepinephrine. So, if it prevents the reuptake, there is excess norepinephrine at the effector junction, which means it results in pupillary dilatation. So, in normal people, that is you, me, they, everybody, cocaine causes dilatation of the pupil. If you find it difficult to remember, just remember cocaine is a drug of substance abuse. And therefore, if all of us who are not used to it, we take cocaine, pupil will be dilated. Okay. There is a small possibility that in some people where there are synechiae, the pupil may not dilate. You should have checked the pupil beforehand in the slit lamp. But if you still are doubtful, add 10% phenylephrine. If synechiae are present, the pupil still will not dilate. But if there are no synechiae and it is a pure Horner, then the phenylephrine will cause dilatation of the pupil. Now, coming to apraclonidine, we all know it's an alpha-2 agonist. So, alpha-2, till now we never spoke about alpha-2 anywhere. Alpha-2 receptors are present on the presynaptic terminal. Another important point you need to remember is, in general, in the body, alpha-1 is stimulatory, alpha-2 is inhibitory. So, alpha-2 agonist means it causes the alpha-2 receptors cause inhibition of what? They inhibit the release of norepinephrine. If they inhibit norepinephrine, there is no norepinephrine. It either has no effect or sometimes due to mild, that parasympathetic overactivity, a mild meiosis may be there. So if you notice, this is the exact opposite of cocaine. Okay, so cocaine is a substance abuse drug. All of us get dilated pupils. Apraclonate is a poor anti-glaucoma drug, doesn't cause any problem, doesn't affect all of us. No dilatation. Coming to hydroxyamphetamine. Hydroxyamphetamine, it releases the already stored epinephrine from the vesicles. So it goes up to the vesicles and says, come, get out. Okay, so the norepinephrine that is released acts on the alpha-1 of the iris and causes mydriasis. So again, this is a drug of substance abuse. Remember, drugs of substance abuse in all of us causes pupillary dilatation. So remember, in normal individuals, cocaine and hydroxyamphetamine cause mydriasis, apraclonidine either no effect or miosis. Now, let's see what happens when we use these same drugs in eyes with Horner syndrome. Remember, cocaine prevents the reuptake of norepinephrine. So whenever there is a sympathetic lesion, regardless of the site of the lesion, okay, the action potential doesn't reach the postganglionic neuron, which means there is no norepinephrine to be released, and therefore there is no effect. So remember, all of us dilated with cocaine, but the Horner guy is not going to dilate. What about apraclonidine? Alpha-2 agonist, fine. All of us know it's an alpha-2 agonist, but what many don't know, it also has weak alpha-1 activity, which in normal situations is not a big deal. However, whenever there is a sympathetic lesion, again, regardless of the location, there is upregulation of the alpha-1 receptors on the iris dilator, meaning there is denervation hypersensitivity. Now this weak alpha-1 activity starts acting and it results in pupillary dilatation. Okay, so now apraclonidine causes dilatation of the smaller Horner pupil, resulting in a reversal of anisocoria. Okay, so the way to remember this is apraclonidine causes reversal of anisocoria. In whom? In patients with remember, for denervation hypersensitivity. Okay, so apraclonidine causes reversal of anisocoria in patients with denervation hypersensitivity. What about hydroxyamphetamine? We said it releases norepinephrine. Now, this is dependent on the site of the lesion, unlike the other two drugs. Now, if it is a central or a preganglionic lesion, so let's say there. Now, there is a lesion, the action potential may not reach the postganglionic neuron, but the norepinephrine stores are intact. It doesn't harm them. So adding hydroxyamphetamine does result in release of norepinephrine and there's a pupillary dilatation. So just like normals, the people with central and preganglionic pupil will dilate. However, the postganglionic neuron is a different story. Here, there is a destruction of the postganglionic neuron, as a result of which there are no norepinephrine stores at all. Therefore, there is nothing to release. Therefore, there is no effect. Okay. Now, how to remember? In of hydroxyamphetamine, it increases norepinephrine. In whom? In normals and early lesions. So by early lesions, I mean central and preganglionic. So in normal and early lesions, there is dilatation of the pupil. Okay, right. Now, finally, let's come to the drug testing protocols. Now, when we think of drug testing in Horner, there are two questions that need to be answered. One is, first of all, is there a Horner? And if it is there, where is the lesion? Where means we cannot pinpoint the exact location. We can basically decide whether it's a postganglionic or not. Cocaine and apraclonidine answer the first question. Hydroxyamphetamine answers the second question. Now, cocaine is available as a 4 or 10% solution. 2 drops are administered 5 minutes apart. In which eye? In both eyes. All these drug testing protocols, they have to be administered in both eyes. Only then can we compare between the normal and the abnormal. And you observe after 60 minutes. Now, another thing, all these tests should be performed in dim light. You do it in something like a cricket stadium with floodlights, the pupils are going to be so small, you will not be able to observe a meaningful reaction. Second, in the subsequent examples that I show you, in all of the cases, the right eye has got Horner syndrome and therefore is the smaller pupil. So now we are going to instill cocaine. Okay. Now look, the cocaine, the Horner pupil has not reacted, whereas the normal left eye has reacted. So regardless of the pre-cocaine size, a post-cocaine anisocoria of greater than 1 millimeter is diagnostic of Horner. Now, here I must tell you that there are some resources which say that 0.8 millimeter itself is diagnostic, but American Academy has mentioned 1 millimeter, so I am going with that. Now, coming to aproclonidine, it is available as 0.5 or 1%. We put 1 drop in each eye, observe after 45 to 60 minutes. So here we go. Okay. And can you see the beautiful reversal of anisocoria? This is diagnostic of Horner. Of course, there will also be elevation of the eyelid, but that is non-specific. It's not specific to Horner. Now, let's come to hydroxyamphetamine. Now, whether you tested for the presence of Horner with cocaine or aproclonidine, you have to give at least 48 hours before you test with hydroxyamphetamine. Because first of all those reactions, if you do it immediately, all those reactions, it's going to create a whole lot of confusion. Plus, cocaine prevents the uptake of hydroxyamphetamine. It is going to interfere with the test. So we use 1%, 1 drop in each eye, observe after 40 minutes. Let's see what happens. Both have dilated. So, like we said, the early lesions, central and preganglionic, behave like normals. The Horner pupil has also dilated. So, this is this. Now, watch this. Now, here what has happened is the Horner pupil did not dilate. So, this is clearly a postganglionic Horner. So, which means there is an increase in the degree of anisocoria, because only the normal pupil is dilating. And in general, if the anisocoria increases by at least 0.5 millimeters, it is very likely to be a postganglionic Horner. Now, drug testing is not as straightforward as I just discussed. There are some problems, especially with cocaine availability. It is a controlled substance. It is not available commercially anywhere in India and in most parts of the world. And in those places where it is, it's very difficult to obtain and it is expensive. So that is a major problem with cocaine. Aproclonidine, that problem is not there. It is freely available. However, do you remember we mentioned that it acts in denervation hypersensitivity? We all know that denervation hypersensitivity does not occur overnight. So today is February 16th. If the patient comes today, it takes at least 2 to 5 days on an average for the denervation hypersensitivity to develop. Now, if the patient comes with an acute internal carotid dissection, you cannot wait for 2 to 5 days. Patient has to go for imaging. Okay. If you get a painful Horner, okay, Horner syndrome with an ipsilateral pain on the face, it is an internal carotid dissection. Unless proved otherwise, please don't wait for testing. Directly take the patient for imaging. Another thing. I said 2 to 5 days, but in some patients, it can even take up to 2 weeks. Okay. Now, in very young children and infants, aproclonidine can cause CNS depression and respiratory arrest. So, in such people, cocaine is a safer drug to use. Coming to hydroxyamphetamine. Now, remember I said it releases stored norepinephrine, and there are no norepinephrine stores in a postganglionic neuron. Fine. But as soon as a lesion occurs, what about the stores that are already there? They take about 1 week to get depleted. So within the first week, hydroxyamphetamine testing is not reliable. And of course, again, it's a controlled substance, same problem as cocaine. It is not available today. Hydroxyamphetamine has been given up. So now, having discussed all this, you may get certain doubts. Let's try to address what I think you may be having doubts about. Now, with all this, is there any role at all for drug testing in Horner? In some conditions, yes. A patient presents with physiological anisocoria, probably the most common condition you need to differentiate from Horner, or a partial sympathetic palsy. Okay, only ptosis, only anisocoria, or a diffuse sympathetic neuropathy where there's a bilateral honor, there is no asymmetry, so you might miss it. In such conditions, drug testing is useful. Physiological anisocoria, why it is so difficult sometimes to differentiate from honor is both you have normal pupillary reactions, both the anisocoria is greater in dim light. However, one key difference between them is there is a dilatation lag in Horner syndrome when you take the patient to a dark room, which is most noticeable in the first 4 to 5 seconds, that disappears after 15 seconds. Okay, this itself is enough to differentiate between the two conditions. But if the results are equivocal, you're having a problem, you can go ahead with drug testing. Next. Can brimonidine be substituted for apraclonidine? After all, brimonidine is also an alpha-2 agonist. Not at all. It is a highly selective alpha-2 agonist. It doesn't have that weak alpha-1 activity of apraclonidine. Don't even think about it. Next, is there a role for phenylephrine in testing? Now, this is, you can't like a lawyer say yes, no. It's not a simple yes, no answer. See, of all the drugs we have discussed so far, phenylephrine has the weakest link with respect to reliability for Horner testing. Basically, some authors suggested phenylephrine simply because hydroxyamphetamine is not available. It was suggested as a substitute for hydroxyamphetamine. But we know that phenylephrine 2.5, 5 and 10% dilates the normal pupil. So these authors suggested using dilute, that is 1% phenylephrine, which they claim does not dilate normal pupils, but dilates a post-ganglionic Horner due to denervation hypersensitivity. That logic, however, goes outside the window because denervation hypersensitivity occurs regardless of the location of the lesion. That is how we are using apraclonidine. The authors themselves say that it is unreliable. So even authentic textbooks like American Academy do not even mention phenylephrine. The only reason I mention is that some of you may have come across it, so I want you to know what's happening. So to summarize, cocaine prevents reuptake of norepinephrine and causes dilatation in normals regardless of the site of the lesion, but not in Horners. Apraclonidine again, regardless of the site, causes reversal of anisocoria in patients with denervation hypersensitivity. Hydroxyamphetamine increases norepinephrine and therefore causes dilatation in normals and in early lesions. And finally, I would like you to remember these two words, CAP and HEL. CAP stands for cocaine and apraclonidine are for detecting the presence or absence of Horner, whereas hydroxyamphetamine is to differentiate between early and late lesions. Thank you.
Thank you so much, ma'am. Thank you so much for this informative and interesting lecture on a very intriguing topic. Love the animations and the mnemonics. This topic never felt as easily understandable as it did today. So with this, I request the panel for the expert comments. Dr. Ankur Sinha, please.
I think I'll congratulate Dr. Annapurna for making things very simple for PGs because this has already been a very confusing thing for them that which drug does what in Horner syndrome. And I think the very basic reason why we want to discuss Horner syndromes of all the pupillary abnormalities is that there is a possibility of having a life-threatening lesion which can be there with the Horners, but maybe not with the ADs. So that's the importance of having a smaller pupil being abnormal as compared to a larger pupil being abnormal. So I think that's nicely put up. I hardly have anything to add to this, ma'am. And your mnemonics were really too good. I think if PGs could go back and remember these mnemonics, they would never fail to understand which drug stands for what in these particular kind of diseases. Congratulations again, ma'am.
Thank you.
Yep, I just wanted to add something. I think Dr. Annapurna, it was an excellent talk. I mean, it's just hats off your presentation and the way you've explained the topic is you've made it so easy for everyone to follow. So congratulations, as I really echo with Dr. Ankur in saying that. And one more thing, as he pointed out, is that Horners can sometimes harbor a neuroblastoma, more so if it is a early onset and acquired Horner. So I think one more point is also to be able to differentiate whether it is a congenital Horners versus an acquired Horners. Because if it is congenital seen from day one, probably less likely, and we may not need to go all the way with the testing and the neuroimaging. And also, when we ask for the neuroimaging, it has to be up to the chest, that is including the head, neck, and the upper chest, because we cannot rule out any, because that way we can rule out any affected lung tumors. So that's just one little thing. But excellent talk. Thank you.
Dr. Kavita, ma'am.
Yeah, I just wanted to ask for a beginner or not a person not exposed to these cases much, what is the thing that we should not miss clinically? If we find there is an esocoria as a
So,
beginner,
yeah, so maybe I can start and maybe others can add on.
no, I'm just asking mainly for discussion and the students, if it will be useful for them.
Yeah, exactly. So one thing is to be able to do a very good clinical examination and to first of all confirm that this anisocoria is pathological. Okay, because there can be physiological anisocoria. So really testing in light, testing in
Right.
dark, and testing in near has to be the crux to begin with. And then doing the confirmatory tests once we are narrowing down a differential that no, this is an isocoria greater in the dark, not in the light, because then we are looking at a different set of problems or a different set of pathologies. So I think it is a very stepwise approach that is required in these cases, and always keeping that suspicion that we, at the end, we want our ophthalmology trainees to be competent and safe, not miss things and not even order unnecessary things. So the initial clinical part I think is really important in a stepwise manner, and then looking at narrowing down your differentials and then ordering a confirmatory test to go about. I think I don't know if that answers your question partly, but
Yeah,
maybe.
because we are not going to do any of these tests, these drug tests. So
I
the
just
only one thing testing is the dim and the bright light pupil size and the way it is reacting and the time that it takes to to show its results. Is this something which we have to see? Is there any particular way that we have to examine the pupil if that could be highlighted?
No, I
I
think it
just
has been nicely discussed that we have to see it in the dim light. As ma'am very clearly said, the stadium floodlights, you won't have any pupillary abnormality. So I think as Dr. Manjushi also said that it is important to highlight which pupil is abnormal, whether the smaller one
Yeah,
or the
or
larger
the
one.
larger one. Yeah,
Yeah, that's the crux of
correct.
everything. The commonest thing which we get, I think most of us, is bilaterally dilated fixed pupil. So that's usually physiological. So, I mean, that's not physiological, pharmacological,
Not
sorry.
for
Yeah,
pharmacological.
that's usually pharmacological. So that's one thing to be very, very important to me, I think.
I'd just like to add one thing. Am I audible?
Yeah, yeah.
Yes, ma'am.
As far as the physiological anisocoria is concerned, the list signs, the mild ptosis, usually we are able to see these signs, mild ptosis, the lower lid slightly move upwards, and apparent enophthalmos. These things will be missing in a physiological anisocoria. Then if look for the anhidrosis, at times the flushing, which is more prominent in the ear lobule, slight congestion, some vascularity, if we examine the fundus. So these are the other ancillary signs, add-on signs, by which we can differentiate. Now, once we are able to see that these just the signs are there, then this is a Horner syndrome. Usually, any one of them will be there, but in a physiological case, these lid signs and etc. will be missing. and then variation in the size in dim light, and lastly, the most important thing is the dilatation lag, which it should clinch the diagnosis. That is something, because what happens nowadays, ma'am has rightly pointed out, Horner syndrome is a syndrome which, if missed, can be associated with, especially I'm talking about secondary Horners, not primary Horners or isolated Horners, because secondary Horners, if it is missed, then there can be various life threatening conditions. So this is a topic which at times is missed while we are teaching a postgraduate students. And this, madam, you remind me of my pre-clinical days, my physiological teachers who taught these things, are pharmacological, so nicely, beautifully described. और अब मुझे भी शायद पढ़ने की जरूरत नहीं पड़ेगी, और school, I'll ask everybody to go through your slides, make the thing so simply, not only for the clinician, even for the undergraduate and the postgraduate students, ma'am. Thank you so much.
Dr.
Thank you.
Anupama, you have done a wonderful job. Even I thought it made my ideas very clear about, because every time we read it, we don't apply it, we don't remember, but the way you have told it, I think we are going to remember it. And of course, we have to emphasize on the clinical aspect, but this is very important for the postgraduates, because they routinely get a question on this, or so they should understand, and it's not a thing which they can memorize. So if they understand it, then for them to reproduce is better.
Thank you so much, ma'am. Thank you so much for the informative lecture. Without further ado, I'd like to move on to the next. Next, we have Dr. Snehal Thackeray, who would be talking about a clinical approach to diplopia. She's working in MGM Medical College and Hospital, Aurangabad. She's done her MBBS from Bharati Vidyapith Medical College, Pune, and MS DNB Ophthalmology from Pravara Rural Medical College, Loni. She's also done a short-term fellowship in pediatric ophthalmology and strabismus from LVP Prasad Eye Institute, Hyderabad. She's been assistant professor and associate professor and currently professor at MGM Medical College, Aurangabad, and she's delivered various presentations nationally and internationally. Welcome, ma'am. Please share your screen.
Good evening, everyone. I will just share my slides. Are my slides visible?
Yes, ma'am. Yes, ma'am.
Yes, ma'am. Yes.
Okay. So at the outset, I would like to thank Team GuruSangam for giving me this opportunity, and also like to thank Dr. Siddharth for making my job simpler with his beautiful presentation at the beginning of the webinar today. So my topic for today is diplopia, a clinical approach. The objectives. 1 minute. Okay. So the objectives of today's lecture are to explain why diplopia occurs, explain physiological diplopia, describe a stepwise approach to a case of diplopia, explain fixation switch diplopia, and briefly describe diplopia in a patient post-refractive surgery. So by definition, diplopia is a visual disturbance which is characterized by the presence of, by the perception of double images. If more than 2 images are seen, then it is called as a polyopia. As we know, diplopia can be binocular, which is due to ocular misalignment, or monoocular, which is due to optical anomalies. So before we understand why binocular diplopia occurs, we have to revise a bit of physiology of binocular single vision. So while viewing an object placed at a convenient distance at an eye level in the midplane of the head, only one visual object is perceived by the observer, though separate retinal images are formed in each eye. And this is because of the phenomenon of binocular single vision. Now, few prerequisites have to be satisfied for a person to have binocular single vision. They are that both eyes should be aligned properly with the overlap of visual fields. There should be accurate neuromuscular coordination of both eyes so that the visual axes are directed to the object of regard. There should be approximately equal image clarity in both eyes with regards to size, illuminance, and color. Both eyes should have normal visual pathways. And last but not the least, both eyes should have corresponding retinal areas so that the eyes appear cyclopean like the Greek mythological character Cyclops. So now, how do we get to explain what these corresponding retinal areas? I will go through a few terms. I have so now every retinal point has a directional value. So this is nothing but, just a second. So this is what is called as relative subjective visual direction, with the fovea of the eye having the principal visual direction and all other retinal points having a secondary direction relative to the fovea. Now, every retinal point or area, including the fovea, has a partner in the fellow eye with which it shares a common relative subjective visual direction. These terms are long, but they have a lot of meaning. And these partner points are called corresponding retinal points. All other points are disparate or non-corresponding for a given retinal point in the fellow eye. So each point has only one corresponding point in the other eye. Now, these corresponding retinal points are responsible for what is called as the normal retinal correspondence, where both the fovea have a common visual direction, which is straight ahead, and the retinal elements nasal to the fovea in one eye correspond to the temporal retinal elements in the other eye. So now these, as I have said, the fovea is directed straight ahead, whereas the nasal retina of the left eye is having a temporal visual direction, whereas the temporal to the left, okay, and the temporal retina of the right eye is having a nasal direction to the left. So these are the corresponding retinal points. The stimulation of these corresponding retinal points in the two eyes results in the formation of single image, whereas simultaneous stimulation of disparate retinal points in normal eyes with normal retinal correspondence, which happens in concomitant strabismus, results in a binocular diplopia. So now what has happened here is that the fovea of the left eye is directed to the object of interest, but there is an esotropia in the right eye. So the nasal point is directed to the object of interest. But because of the directional value the retinal points have, the brain assumes that this object, which is projected temporally. So because of this, the patient will experience diplopia, because the brain is adjusted to thinking that the nasal point is directed temporally. So the false image will be placed temporal to the original object. Now, coming to why monoocular diplopia is seen, it can be unilateral monoocular or bilateral. So unilateral monoocular diplopia is due to refraction of light that falls on both the fovea and the extrafoveal points in the retina of the same eye. This is usually seen due to refractive apparatus of the diseases of the refractive apparatus of the eye, the cornea, lens, vitreous body, and sometimes because of the epiretinal membranes too. Whereas bilateral monoocular diplopia or polyopia is usually cerebral in origin. The lesion is in this occipital cortex, more specifically the visual association cortex, and various lesions right from cerebral trauma, ischemic stroke, migraine, encephalitis, seizures or occipital epilepsy, tumors, multiple sclerosis can give rise to this type of diplopia, and this is associated with visual field defects. One more term which we have to know before we go to how to approach a case of diplopia is understand why we have physiological diplopia. To understand physiological diplopia, again, we have to become familiar with two terms, horopter and Panam's fusional area. So by definition, horopter is the locus of all object points that are imaged on corresponding retinal points at a given definite distance. So this is your horopter. And Panam's fusional area is a narrow band around the horopter, front and behind, stimulation of disparate retinal elements within which transmits the impression of a single vision. So stimulation of points within the Panam's fusional area results in a single image, whereas stimulation of points while fixing at an object at the horopter, if an object is placed in front or behind, you will experience a physiological diplopia. So if there is a cross diplopia is experienced when the object is placed closer than the fixation point, and an uncrossed diplopia is experienced when the object is placed beyond the fixation point. So this is important clinically because a person may become accidentally aware of physiological diplopia and may find it troublesome. So thorough examination, the details of which I will go in soon, will reveal that there is no paresis of any extraocular muscle or any other cause of diplopia, and this must be explained to the patient, and he should learn to ignore this physiologic diplopia. So now coming to the second part of my lecture, which is a stepwise approach to a case of diplopia. So first, if the patient complains of diplopia, you have to confirm that the patient really has diplopia. You can ask the patient to draw what he or she is actually seeing, because sometimes in uncorrected refractive errors, especially astigmatism, the patient may assume it's diplopia, whereas it's just blurred vision. You can place a vertical prism in front of one eye of the patient and demonstrate to the patient what a diplopia actually looks like. Once you have confirmed that the patient really has diplopia, next step is to decide whether it is monoocular or binocular. This is done by covering either eye at a time, and the operative word is either, because in binocular diplopia, the image will disappear if either eye is covered, doesn't matter which, whereas in monoocular diplopia, the image will disappear only when the affected eye is covered. If the patient insists that he or she is seeing more than two images of equal clarity and or the diplopia is bilateral and monoocular, think of it being a cerebral diplopia or a polyopia. Now note the presence or absence of obvious strabismus, because an absence of obvious strabismus does not rule out binocular diplopia, as may be the case in subtle palsies, decompensating phorias, divergence insufficiency, or convergence insufficiency. Once it's confirmed that the patient is having a monoocular diplopia, you do a pinhole test. If the image becomes single, it is the problem is in the refractive apparatus of the eye. It can be media opacities, tear film abnormalities, corneal or lenticular astigmatism, subluxated IOL, a large post-op iridectomy, or a traumatic iridodialysis, or a higher order aberration after refractive surgery. If the image remains double through the pinhole, you think about a macular pathology like epiretinal membranes, cerebral or cortical diplopia, or a polyopia after head injury, CVA, or it can be palinopsia. So, and if the patient does not fit into any category, go back to the history. Many drugs, I have just named two, can cause a diplopia, or it can be psychogenic in origin, or there can be a functional disorder like convergence spasm. A complete ocular evaluation, right from cycloplegic refraction to wavefront analysis, if the patient has undergone refractive surgery, is essential to rule out the cause of monoocular diplopia. Now, if the patient is having binocular diplopia, spend some time taking history of the patient, because the history will not only give you clues towards possible etiology, but also towards which muscles are involved. So the etiology can be ocular or non-ocular. In ocular, if there are dissimilar images, it can be an ERM. If there is history of surgical procedure for deviation, it can be a paradoxical diplopia. If there are no specific complaints, but there are similar images, it can be a physiological diplopia. Now, in non-ocular etiology, there are many causes. So if it is a sudden onset diplopia, which is constant, their history of diabetes or hypertension may or may not be present, or the patient may be recently diagnosed, or you may cause the diagnosis of these conditions. It can be an acquired cranial nerve palsy of an ischemic type. If it is associated with a history of severe headache, it can be a partial third nerve palsy, vascular type, because of a posterior communicating artery aneurysm. If there is variability in the amount of diplopia more later in the evening, if there is fatigability of ocular, lid, or other muscles, it can be myasthenia gravis. If it is a transient or intermittent diplopia, which is horizontal in nature, it can be a decompensating horizontal phoria, usually intermittent exotropia. Or if it's vertical, it can be a congenital superior oblique palsy, which is decompensating. A closed head trauma with a rumbling noise head can be a cavernous fistula. Or with a complaint of vertical diplopia, it can be a traumatic superior oblique palsy also. If there is imbalance, abnormal gait, other sensory or motor symptoms, it can be a CNS etiology. If there is pain in the eye, headache, proptosis, it can be an orbital pathology. If the patient is a known case of thyroid eye disease, with or without lid soils, with recent onset diplopia, it could be a thyroid eye disease. So a proper history is very important. Coming to asking more about the images. If the images, I'll ask about the alignment of the images, whether the diplopia is horizontal, vertical, tilted. It will give you an idea about which muscles are involved. The direction in which the images are maximally separated will tell you which eye is involved. So suppose the diplopia is worse for distance, it can be a divergence insufficiency. Worse for near, it can be a convergence insufficiency. A purely vertical diplopia will be seen in superior oblique palsy or skew deviation. Diplopia in more than one gaze with obliquely aligned images can be third nerve palsy, myasthenia gravis, or orbital disease. If the diplopia worsens in up gaze, it can be superior rectus and inferior oblique involvement of third nerve palsy and myasthenia gravis. Diplopia worsening in down gaze, it can be inferior rectus palsy or superior oblique palsy, and again myasthenia gravis. Horizontal or oblique diplopia with difficulty in horizontal tracking, it can be in internuclear ophthalmoplegia. And as you can see, myasthenia gravis is a great mimicker. So if you can't find anything, you must rule out myasthenia gravis. Examination begins with observation. You observe for any obvious deviation, any adopted abnormal head posture, or spontaneous closure of one eye. They will give you an idea about the incompetency. A complete strabismus evaluation, which Dr. Siddharth has explained so well in this first lecture, with special emphasis on measuring of primary and secondary deviation. You measure the deviation by placing the prisms in front of either eye separately. And so if you will know whether there's primary or secondary deviation. This is very essential. And emphasis cannot be given more on examination of ocular motility. All reductions, versions, saccades, everything should be tested, because sometimes it can happen. There are full versions. There is no obvious strabismus, but the patient complains of diplopia. We check the saccades. They could be slowed in subtle palsies, neuromuscular junction disorders, or myopathies. Or they may come for a jerky stop in restrictive myopathy. Sometimes there are full versions with recent onset esotropia. Then it can be an acute acquired comitant esotropia. Full versions with intermittent exodeviation. It can be decompensating intermittent exotropia. So then once you have done this, you go to examine the diplopia properly. A red glass test, just placing the red glass in front of one eye, will dissociate the two eyes, and the diplopia will become manifest, which will tell you whether it is uncrossed in esotropia, crossed in exotropia, vertical or torsional. In paradoxical diplopia, the diplopia will be opposite of above, like it will be crossed in ET, and there is a history of surgery for strabismus. To confirm the presence of secondary deviation, ask whether the separation of the images is greater with the red lens placed over one eye as compared to the other eye. The details of the diplopia can be simply charted by using the red-green glasses in the OPD. So what do? Is you make the patient wear red-green glasses and sit at 1 meter distance from a plain wall, and you project a streak of light with a streak retinoscope or with your ophthalmoscope. Before that, you make preparations to mark this diplopia. You make a box with 9 parts and mark which glass is in front of which eye, because sometimes you can even get opposite green-red glasses. Then you demonstrate to the patient that he should use his 2 fingers to show the image of the right eye and the left eye. And then he can use these fingers, index fingers, to show how far the images are apart, whether they are only horizontally separated or vertically separated, whether there is any tilt. And accordingly, you should mark in these 9 boxes. So the rules for analyzing this box are: first, you should observe gaze in which the diplopia is maximum or the images are most widely separated in your chart. You should know the muscles which are acting in this gaze. And then you should remember that the most distal image belongs to the affected eye. So simple example is, here you can see that in the right gaze, the images are most widely separated. The muscles acting in this gaze are the right lateral rectus and the left medial rectus. The red image is of the right eye. So this is a right lateral rectus palsy. A little bit difficult one. Here you can see that the image is most widely separated in levodepression. Muscles acting in this gaze are left inferior rectus and right superior oblique. The most distal image is the red one belonging to the right eye. So this is a right superior oblique palsy. And similarly, here you can see this is a left superior oblique palsy. So this diplopia analysis will tell you whether there is an isolated cranial nerve involvement or multiple cranial nerves or muscles are involved. If multiple cranial nerves are involved, then you should suspect an inflammatory, infiltrated, or compressive lesion, which could be anywhere at the base of the skull, cavernous sinus, orbital apex, or superior orbital fissure. And again, a complete ocular examination should never go amiss. And you should also take a neurology opinion, especially if there are complaints of ataxia, abnormal head or eye movements, hoarseness of voice, or ptosis. You yourself should be able to examine all the other cranial nerves. So that will also help you in localization of the lesion, if there is an intracranial lesion. Now I'll come to some specific signs of specific diseases. So if there is an epiretinal membrane which causes monocular as well as binocular diplopia, the binocular diplopia is due to retinal registration, which is misalignment of the retinal elements that affects the central and peripheral fusion. And these are very specific tests which can help you diagnose and confirm your diagnosis: the light on-off test, the optotype frame test, and the synoptophore test. In this test, if you ask the patient to look at the optotype, single optotype, if he sees double, only the letter is double or only the frame margin is double, it's the epiretinal membrane. If this is both the letter and the margin are double, then it is an cause due to a binocular diplopia due to paralysis. In the synoptophore test, all these boxes and these squares should coincide if there is no diplopia. If even one is misplaced, then it is an epiretinal membrane. Systemic diseases, specific signs for systemic diseases. In thyroid ophthalmopathy, there'll be ledge signs, proptosis, and the FDT will show in inferior rectus tightness initially, along with medial rectus in the later stages. In skew deviation, patient may complain of torsional or vertical diplopia, nystagmus. The hypertropia will not change with head tilt, but it will disappear on making the patient lie supine, as in the upright supine test. And of course, there'll be other associated neurological signs of ataxia, gaze palsy, dysarthria, etc. In myasthenia gravis, the great mimic, the diplopia does not follow any specific pattern. There is history of variability, and the other signs for myasthenia gravis may be positive, and the neostigmine test may be definitive in diagnosis. So if a patient is more than 50 years of age, the microvascular ischemia is the more common cause. So you will do sugars, BP, hyperlipidemia. If it does not improve, you go in for neuroimaging. If the patient is less than 50 years of age, neuroimaging is your first investigation of choice. And it should be MRI brain, orbits, fat suppression, contrast, MRV, MRA, the whole works to rule out posterior communicating artery aneurysms, any space-occupying lesion, and demyelinating lesions. Two special situations I would like to discuss. One is the fixation switch diplopia. This is more important for the next situation of diplopia after refractive surgery. So now, as the name suggests, when the fixation switches from the dominant eye to the non-dominant eye in an adult patient with a non-alternating childhood strabismus. So there is strabismus in one eye or an amblyopia, and the fixation switches to the non-dominant eye, the amblyopic eye, then your patient will experience diplopia. This is called as fixation switch diplopia. The speculated mechanism for this is that the suppression that accompanies the strabismus is facultative, and it is not present in the usually dominant eye when the non-dominant eye takes up fixation. So therefore, there is a perception of diplopia. Now, some situations when this can occur is the development of myopia in a previously preferred eye in patients with mild contralateral amblyopia. Now, an example for this is if the patient is plano in the right eye, is having mild hypermetropia and mild amblyopia in the left eye. Now, as the patient grows older, patient becomes myopic, so the vision of the right eye is becoming lesser. This eye is having mild amblyopia, so it becomes lesser than the left eye. So the left eye takes up fixation, and then the patient perceives a diplopia. This is a fixation switch diplopia. So if you correct the refractive error in the right eye, the complaints will disappear. Induced monovision. Monovision is used as a treatment for presbyopia when one eye is corrected for near and one eye is corrected for distance. So this can be an optical procedure. It can be a refractive procedure. So for LASIK and all. So then and this patient already had childhood strabismus, history of treatment for strabismus, amblyopia, etc. So if you induce monovision in this eye, if the eye with the lesser vision takes up fixation for distance or for near, there can be fixation switch diplopia. When patients with mild amblyopia receive an unbalanced or incorrect refraction that leads to fixation in their non-dominant eye, can also lead to a fixation switch diplopia. Now, coming to this entity, which many of our refractive colleagues who are doing refractive surgery might be encountering. I hope they do not. But then this is a chart which I've taken from Dr. Kushner's article, which is beautifully self-explanatory. So as with other diplopia, you see whether it is monoocular or binocular. If it is monoocular, it is because of corneal scarring or opacity. The target area is smaller than recommended or decentralized. Then you have to refer this to the appropriate anterior segment surgeon. If it is binocular, then you should rule out whether there is monovision present or absent. If monovision is not present, then you just do a cycloplegic and manifest refraction and correct any refractive error which is present and await optical rescue. You wait for it to spontaneously correct. If it persists, and then you go in for prisms. If there is squint, you go in for surgery, or you can try orthoptic treatment. If monovision is present, then you check, this could be a fixation switch diplopia. You eliminate the monovision. You basically make the vision similar in both the eyes. If one eye is undercorrected, you correct it completely. The diplopia will disappear. If there is no fixation switch, even then you should eliminate monovision and await optical rescue. If still persists, then you go for prism surgery or orthoptics. So prevention is better than cure, as we know. So for that, for any refractive surgery patient, you should ask history of strabismus, use of prisms, patching or orthoptic exercises. Now, patients may not remember whether there are prisms in their glasses or not. You check the patient's eyeglasses for prisms or bifocals. Basically perform a strabismus evaluation for distance and near, especially when you're planning monovision. A contact lens trial can be given to determine how these patients respond to the correction at the level of the cornea. In hyperopes, determine the maximum degree that allows threshold visual acuity at the cycloplegic refraction and then correct accordingly. So treatment is basically symptomatic relief, prisms occlusion, epiretinal membranes may not respond to prisms, and surgery is an option only when there is no spontaneous resolution. Definitive treatment is treatment of the cause. To summarize, you have to confirm the presence of diplopia, occlude either eye to differentiate between monocular and binocular diplopia. Do the pinhole test, it will guide you towards the cause of monocular diplopia. If there are multiple images, think about a cortical cause. Remember, diplopia can be present in the absence of any obvious strabismus. Binocular diplopia can be present in absence of obvious strabismus. Thorough history, thorough evaluation, included strabismus evaluation is a must. Remember the 3 rules of diplopia analysis. See where the image are most widely separated. Know which muscles are acting in that direction. And observe which is the most distal image. And remember which lens is placed in front of which eye, and accordingly you can find out which muscle is involved. Investigate according to the age of the patient. Ask for history of childhood strabismus, amblyopia management in adults with sudden onset diplopia to rule out fixation switch diplopia. In patients with diplopia post-refractive surgery, rule out monovision and fixation switch diplopia. Thank you.
Thank you so much, Dr. Snehal, for a detailed yet compact presentation on approach to diplopia. Requesting panel for the expert comments. This time I would like to start with Professor Simizak.
Dr. Snehal, you have talks in great detail about diplopia, not only for strabismologists, but for an ophthalmologist, we have to look for not only for the paralytic squint, but so many causes of binocular diplopia as well as the monocular. Madam, what about his charting? I think this is a very important role as far as the prognosis of diplopia is concerned, as far as following the diplopia is concerned, and to find out which muscle is at fault. And later on.
Yes, it should be done. But I omitted it. I thought I might overshoot because I tend to either go slow or go very fast. But of course, it definitely plays a role. It should be done. And because that will help you find out, especially in a paralytic squint, it will help you find out which muscles are involved. If there are many muscles, if it's a multiple nerve pulse, many muscles are involved. Sorry. It will help you diagnose better, definitely.
Basically, in a teaching institute, we have to teach our students
Yeah.
basically which eye is for the head charting, which eye is the fixing eye, which eye is non-fixing eye. So these are the
Yes.
things which are important at times because not only for the ophthalmologist, for even neurosurgeons, neurologists, diplopia charting is something which tells about the prognosis as equally important to the fundus examination because we get references for the diplopia charting by the neurosurgeon. Otherwise, ma'am, this was definitely a very lucid presentation. Every aspect of diplopia was covered up. Thank you, ma'am.
Thank you. Thank you.
Thank you, ma'am. Dr. Shubhangi, ma'am.
Yeah, it was nicely covered, Snehal. You covered almost all the aspect as madam has pointed out. HES charting, I believe, is a very important because diplopia charting is a subjective test, whereas HES charting is a more objective test, and it helps you in the follow, especially in whether there's a development of contractures in the medial rectus in cases of LR palsy and helps us in speeding up the management of cases. One thing I just wanted to point out is the history in cases of diplopia cases. So many of my patients come with a diplopia with all the investigations for myasthenia done, and we found that they have more of ghosting of image or a monocular diplopia, and they have keratoconus, which is missed
Yes.
on examination, and they've been unnecessarily subjected to so many other tests along with brain MRI and the CUM. And secondly, pupillary examination is of another importance. So when there are multiple muscle palsies which are pupil sparing,
Certainly.
myasthenia has to be the first as compared to the other. So those things also go, it's a package.
Dr. Manjushri Bhati, ma'am.
So thank you very much. And first of all, I would like to really congratulate Snehal because diplopia is such an extensive and such a complicated topic that to cover everything in a very limited time span which is allotted and to cover everything in a systematic manner, I think you've done a very great job. So thank you, Snehal.
Thank you, Manju.
There's really nothing much to add because you've covered all the most important points. Maybe just 2, 3 takeaways that if I were a student, I would definitely want to remember is that sudden onset acquired diplopia is something which definitely needs looking into and needs investigations, as you mentioned, based on the age and age appropriate. Very often, children, if they get diplopia, they would adopt a head posture to try and alleviate that diplopia. So a new onset of head posture is also something which I think needs to be looked into. But otherwise, you've covered all the practical aspects. So really, there's nothing to add. Thank you.
Thank you.
Thank you so much, ma'am. Dr. Kavita, ma'am.
Yeah, I want to congratulate Dr. Snehal. The slides are very, very clear. The flow charts and the tables and the columns and the rows, everything. I think if we want to make a presentation, I think we should take Madam's presentation, I think, because
Thank
you
you,
have
ma'am.
summed up extensively. And diplopia, I mean, S chart is a separate
Yeah.
topic, I think. S chart should be a separate topic because it right from the way we conduct the test and the way we have to interpret the chart itself takes a lot of time. I think the society can think of it. The other simple thing that most of the time we feel is diplopia and blurred vision is getting confused clinically. A simple blood sugar test rules out sometimes these problems.
Yes.
First time the patient comes with blurred vision or diplopia, they're confused and they confuse us as well. And if our students are sitting in the OPD, they get confused, and the diplopia charting is done, and everywhere we have diplopia there. And finally, we get confused about the double vision. A simple test like blood sugar actually rules out that there is no diplopia but a blurred vision. But the other thing is the myasthenia, really a real mimicking condition. Nothing you can really find out. I think we should get um, a patient evaluated for myasthenia. Of course, there won't be any extraocular movement limitation in myasthenia. It's only the symptoms which we need to consider. The patient is more symptomatic, but the clinical signs are less. Maybe if it's associated with ptosis and the clear-cut picture of evening symptoms increasing, then it is okay. But sometimes even myasthenia is confusing. But hydrophonium test really drives home the point. I think thank you very much for this elaborate topic. In fact, last week we had a session on grand rounds on diplopia itself. So all these were covered. But now I want to ask one question here. How do we manage the diplopia in case of retinal level problem, retinal layers, not retinal detachment surgery and then diplopia, but epiretinal
Yeah,
membrane or anything related to post vitreous surgery, and then the retina. These patients really it is very difficult. It is not we cannot relieve it with prisms. How do we go about is my question. How do we treat this? It's counseling again, counseling and
Wha-
counseling.
what I read was that if it is intractable, there's only one occlusion. I have not experienced, but what I did when I prepared for this talk. And the other one article which I found was where I got all those tests was that test was before and after the surgery. So they showed that after their peeling of the epiretinal membrane, so they did these tests before and after, and there was a relief of the diplopia.
Okay. Thank you so much, ma'am. This is one challenging thing. If it's the restrictive post buccal surgery, we can give prisms, but not these cases.
Yeah, exactly.
Buccal, they are responding to prisms, but not the vitreous and retinal surgery.
Yes.
Thank you very much.
One point can I
Thank you.
add? One
Sure.
point can
Yes,
I
ma'am.
add?
Sure,
Not
ma'am.
regards to this, but regards to diplopia. Whenever there's a congenital esopalsy, sometimes it is compensated, but in later in life, sometimes it decompensates and they have a diplopia. And so at this time, the family photographs or the family album tomography comes to your rescue. And they have this head tilt right since beginning. So even though the diplopia is acute, they could have a decompensated fourth nerve palsy, congenital fourth nerve palsy.
Yes, and the diplopia is actually when they're looking back. I had one patient who said when they was reversing the car,
Yeah.
when you look back to reverse the car, they would have the diplopia upward.
Thank you so much, Dr. Snehal. Thank you so much, panel. Without further ado, I request Dr. Geeta Srinivasan for the next talk. She'll be talking on approach to ESO deviations. She's working at Eye Hospital, Noida. She's the consultant pediatric ophthalmologist, strabismologist, and neuro-ophthalmologist at Eye Hospital, Noida. She has 25 years clinical experience with teaching experience for DNB students, junior residents, and fellows for the past 18 years. She's delivered a lot of oral presentations and posters, instruction courses, and workshops as national faculty in various forums. Awarded with the E.C. Agarwal Trophy, SAARC Award, Allergan Award for Best Paper. She was also recently awarded for Reviewer IJO and Poster in SPOCY. She's published a lot of peer-reviewed publications and book chapters. She's been the reviewer for national, international peer-reviewed journals. She's an alumnus of IIM Kozhikode after completing a course on healthcare management analytics. She's recently published a book of poems called Reflections. Thank you so much, ma'am. Please share your screen.
Am I audible and is my screen seen?
Yes, ma'am. Yes.
Okay. Good evening, everybody. At the outset, before I go into the presentation, I'd like to thank the team AIOS for this opportunity. The topic is approach to esotropia. Just a minute, I'm not able to go to the next slide. Not able to go to the next slide. Why is that so? Here it is. Yeah, okay. So our learning objectives will be to define and to differentiate the main subsets of esotropia, management of the important entities, and to determine when the investigation and evaluation has to be on a war footing. What is an esotropia? An esotropia is defined as a form of strabismus, wherein one or both of the eyes are turned inwards towards the nose. Eso means within, and tropia means turn in Greek. The esotropias are because of either innervational factors and or mechanical factors. If we look at the prevalence of strabismus, it is about 0.77% of all school children, with esotropia being about 3%. Prematurity, low birth weight, family history are important risk factors. So the basic questions when we see a case of esotropia is, when did it start? When does it show up? All the time or sometimes? Why did it happen? Was it a trauma? Is it spontaneous? Is it excessive screen use? What is the issue that is bothering the patient? Is it a cosmetic issue? Is it a non-cosmetic issue, like a diplopia, an abnormal head posture, and asthenopia? After taking a history of many more things, as we'll discuss further down, an appropriate and a good refraction is extremely important and cannot be overemphasized. Then comes the assessment of the extraocular movements and the anterior segment and fundus evaluation. So when we look at the classification, just a minute, can I just give me a minute? Yeah, I'm very sorry. I'm stopping the sharing, just a second. Can you see my slide now?
No, ma'am, not yet.
No, sorry, there's some issue here. Just give me a second.
Anything that the tech team can help you with, ma'am?
I'll just see if I'm able to. No, I should be able to, I suppose. You can see it now, right?
Yeah. Yes.
Yeah. Just a minute. Can you see it now?
Yes, ma'am. Yes.
I'm sorry. I'm really sorry about this. Yeah.
No problem. No problem.
So after going to this, we come on to the basic classification of an esotropia. Esotropias can be classified into concomitant deviations, incomitant deviations, and secondary deviations. I'll be going more in detail about concomitant esodiviations today with the time in hand. Concomitant esodiviations mean that the deviation is equal in all directions of gaze. Under this, we have the accommodative esotropias, the non-accommodative esotropias, the nystagmus blockage syndrome, and the microtropias. When we talk of an incomitant esotropia, we are talking of paralytic and non-paralytic esotropias. And when we talk of secondary, we are talking of sensory and consecutive esotropias. Let's talk about all of this in detail with some case scenarios. Comitant esodiviations. Comitant esodiviations are divided into refractive accommodative esotropias, non-refractive accommodative esotropias, and partially accommodative esotropias. Coming to refractive accommodative esotropia, an esotropia due to increased accommodative effort or an abnormally high AC by A ratio is called a refractive accommodative esotropia. More than 50% of all childhood esotropias are accommodative esotropias. Now, if we see a child like this in our OPD with about 15 prism diopter of esodiviation in the eye, we do a hypermetropic correction and with a prescription of 3.5 diopter sphere and 2.5 diopter sphere, and we can see that she's fully aligned. Similarly, another child, a little less than 2 years of age, presenting with an esotropia like this, and on refractive correction, getting aligned like this. Oh, there's some issue happening here. So, when we look at a clinical presentation of a typical refractive esotropia, what we find is a child coming to us essentially between 2 and 3 years of age, though nowadays we are finding younger children, even up to 1 year of age, who are coming to us with accommodative esotropia because of excessive screen time. On evaluation, they would have a squint, which would show us a variability, and a hypermetropia of +2 to +6 diopter sphere. The deviation for distance is equal to the deviation for near. The esotropia is intermittent to start with usually, and asthenopia and closure of one eye can be present. Amblyopia is not usually seen unless there is a severe anisometropia. So now, when we go to the typical presentation, see the 6-year-old child here who's come to us with straight eyes like this. There's a history of asthenopia and doubling of vision. And then we can see that in our few-minute checkup in the OPD, he's gone up to a 10-degree deviation here of esodiviation, about 15 15-degree esodiviation here. So this is the typical presentation of an esotropia where the accommodative factors would cause this kind of a variability in the esodiviation. We have to do a cycloplegic refraction under atropine preferably so that we cycloplege the eye completely before we give the final refractive hypermetropic correction, which we did for 0.5 and 3.5 and see the alignment. So allow at least 6 weeks of usage of the glasses before we go ahead with our next step, 6 to 8 weeks. Now, why is it that it is seen in children 2 to 3 years of age? It's because the accommodative amplitude is very high at this age, about 18 diopters, which keeps going down with time. So that's the reason it presents at that age. And how much after 6 to 8 weeks, reassess the children. If they have an esotropia of a residue which is less than about 8 prism diopters, it is an acceptable correction, which would give a slight suboptimal binocularity, but that is all right. We need not go for surgery. Now, all of the esotropic children with high esotropia, hypermetropia, do not go into an esotropia. That's because those who show an accommodative effort and try to see would have an excessive convergence. And then if there's an insufficient fusional divergence, they end up with a refractive accommodative esotropia. And those who do not try to accommodate would be orthotropic. And these are the children with an ametropic amblyopia. And if they have a sufficient fusional divergence, they end up with an esophoria. Now, this is the next subset, which we call as a partially accommodative esotropia. Here you can see a child who's showing us about 35 prism diopter deviation, getting corrected to about 20 prism diopters with her hypermetropic correction, giving fully after atropine refraction, needing surgery for this residual ESO deviation. This is another child you can see here who's showing us this esotropia here, residual over here, not very clear, and then took him up for surgery. You can see the residual post-surgery, and then when he uses his hypermetropic correction, you can see that he is well aligned. My slides are moving on their own, actually. Okay. So the practical pointer for any accommodative esotropia would be the variable angle of deviation, which is the most consistent feature.
A full cycloplegic refraction is indicated and full correction if they're able to tolerate it at the first go. Treat any amblyopia prior to surgery if there's a partially accommodative esotrope, and surgery should be done only for the non-accommodative part. Always remember to examine the siblings, the family members, because you do have an autosomal dominant component here, as we can see in these siblings. 30% of them may develop a non-accommodative esotropia, which means they will need surgery. Though in practice, I don't see as much. Do an annual cycloplegic refraction and keep them under follow-up. Do not miss any unusual association. Yes, you can see this child here who's got an esotropia in the primary position, getting corrected very well in the primary position with her full hypermetropic correction. But see the limitation of abduction here and the minimal narrowing of the palpebral fissure when she does an adduction. So this is a DRS in association with an accommodative esotropia. Coming to the next entity, non-refractive accommodative esotropia. Here you have an esodiviation at near, which is greater than distance after you've corrected for the hypermetropia. Sometimes, very rarely, these children are myopic also. We should not forget that. And there's an abnormal synkinesis or interaction wherein the amount of convergence for a unit of accommodation is more than it should be. So you have methods like heterophoria and gradient methods to analyze this, wherein the gradient method is said to be more accurate, wherein you assess the deviation at distance and near after putting in either a minus or a plus correction. Note the difference after you've relaxed or tried to increase the accommodative effort. And then if a normal AC bio ratio is present, it should be 2 to 5. Anything more than 5:1 will be considered a high AC by A ratio, and we have to treat such patients accordingly. Now, if you see this child here, orthophoric for distance with hypermetropic correction, and you can see this for near, you can see that with the fixation target, he's got an esotropia of about 8 to 10 prism diopters for near. Now, this is a child, once you do the AC by ratio, give the bifocals and see that the bifocals bisect the pupillary plane. That's extremely important for it to work. A bifocal like this is really not going to do the job. And also prescribe only if the bifocal reduces the near angle to orthophoria. Give the minimum addition that is needed for him to focus for near. Wean off the bifocals with time over a couple of years. Progressives can also be tried, though I found bifocals to be more effective. So when you find an esotropia for near more than the esotropia for distance, add a +3 diopter sphere. This is a good method to do in practice. And if you find that there is a reduction of the esodiviation for near, then by more than 15 prism diopters, we are dealing with an accommodative convergence excess. If it is not showing any improvement, we are dealing with a non-accommodative squint, a convergence excess, for which surgery would be needed. Like I said, even in this case, the onset is about 2 to 3 years of age as a rule, 20 to 40 prism diopters at near, and we find that large MR recessions will work here, bifocals will not work. When we are prescribing spectacles in esotropia, any hypermetropia more than 2.5 diopter sphere, an isometropia more than 1 diopter sphere needs to be prescribed. If we overcorrect, like in this young boy here of about 17 years, you can see the exotropia here, whereas he's actually got an esotropia for near. So undercorrect when you need to follow up annually so that they are binocularly good. Hypoaccommodative esotropia is because of a remote near point of accommodation where there's essentially an asthenopia on near reading in a young individual also. Plus lenses for near do help in these cases. Other methods like contact lenses, miotics, primary surgery, refractive surgery have been described. However, they are not preferred practice patterns. Look for oblique dysfunctions like oblique dysfunction in this young girl here, along with her accommodative component. Look at this young boy here having a superior oblique overaction along with his accommodative squint. These may need cosmetic correction. Recurrent esotropia, we do tend to see this, and as you can see, this child with a right esotropia and corrected with the surgery, partially accommodative. And you can see there's a recurrence of the squint after 2 years. Now, because she came back to us with an RET, this had a BCVA of 6/18 parts, despite occlusion and other treatments given. And we had to take her up for surgery to align her eyes back again. This can happen if there is a residual amblyopia, if the child is not wearing the correct optimal correction, or because of other muscular factors. Coming to non-accommodative esotropia. In non-accommodative esotropia, a very important category is infantile esotropia, acquired basic esotropia, and acute onset esotropia, besides others. Now, when we going to infantile esotropia, let's make sure first that there is an esotropia. This was discussed even before. So you have this large telecanthus here, you have the epicanthal fold here, giving the appearance of an esotropia. However, it could also be a child like this having an esotropia along with a pseudoesotropia, which would need surgery. Some literature says about almost 18 to 20% can present with this kind of a picture. Infantile esotropia syndrome, extremely important. 1 in 400 are said to have an infantile esotropia syndrome. It's seen from birth to 6 months of age, called essential because there is no associated systemic abnormality, and called a syndrome because it has certain classical associations. Vision is usually almost equal in both the eyes. However, one eye may be preferred for fixation over the other eye. It's a constant deviation, 30 to 40 prisms, and it is said to be because of a delay or a deficiency in motor fusion and the Virgin system. The cause exactly is not known, thought to be more at the subcortical level nowadays, previously thought to be at the cortical level. So before saying that it is an essential infantile esotropia in a child like this, make sure that there is no abduction limitation, that this is an concomitant squint. This is again showing us an abduction limitation. This is a case of DRS. So infantile esotropia syndrome, classical presentation, 6 months of age. Refractive error is usually mild to moderate hypermetropia, 90% of them. Some of them may have an accommodative component, which we should not forget. All of the cases would need surgery for proper alignment. So now you have cross fixation, which is a very important classical association here. You can see this child fixating with the right eye on an object which is placed on the left of his field. Nasotemporal asymmetry, wherein an object which we are taking from the nasal to the temporal side is not tracked as well as from the temporal to the nasal side. Again, this, as well as the cross fixation, can be broken only when surgery is done and the eyes are aligned. It's important to remember, most cases will show alternation, but one eye may be dominant and may need patching to have a proper alternation, what we call as a free alternation, before we go ahead with surgery. Classical associations with all students should remember is a dissociated vertical deviation, variously mentioned between 40 and even 60%, a manifest latent nystagmus, wherein you have a hidden component and a manifest component. By occluding the eye, the latent component comes out, and an inferior oblique overaction, which is seen in almost 60, some say even 90%. This may crop up later after 2 years of age, which it does in many cases. So this is your inferior oblique overaction here, which we would need to tackle during surgery. So you see this esotropic patient here. You see the inferior oblique overaction here, which is causing a V pattern, and you need to break that pattern. That can be done only if we do the inferior oblique surgery. Now next, we go on to dissociated vertical deviation. Sorry, I couldn't put up a small child, but the thing is that this can again crop up later. So when you're doing an infantile esotropia, be aware and make the parents aware that this could crop up later and which would need surgery. So this is your dissociated vertical deviation. This is the Spielman occluder, which is being used to uncover the dissociated vertical deviation. Abnormal head postures, if we have it in a congenital esotropia, think of Ciancio syndrome, think of Lang syndrome. Not going into details there, but if you have a nystagmus, abducting nystagmus, abnormal head posture, esotropia, limitation of abduction, think of those variants of infantile esotropia. And to uncover a true abduction deficit, do the doll's eye reflex to check for the movements and do an occlusion to see the abduction of the fellow eye. Sensory adaptations in all squints has been discussed before in our session, suppression, amblyopia, and abnormal retinal correspondence. So we have to manage and treat an infantile esotropia early to prevent irreversible sensory abnormalities, to prevent secondary changes in the extraocular muscles, conjunctiva, and Tenon's capsule. Surgery is classically a bimedial recession with oblique muscle surgery when indicated. Botulinum toxin has been used by some more in the West than here. Now we have two studies, a lot of discussion about when to take up a child with infantile esotropia for surgery. One is the congenital esotropia observation study, which said that any child more than 20 degrees at having a deviation that is stable at 2 visits, 2.5 months apart, if is more than 10 weeks of age, and a hypermetropia less than 3 diopters, take up for surgery. The Ellis study group was early versus late infantile esotropia surgery study, where they said that if you take up at 20 months, stereopsis is good, but your resurgery is higher. You take up at about 48, 49 months, the stereopsis is a little poorer, but resurgery rates would go down. So essentially what is believed now is by 2 years of age, we should be taking up these cases for surgery. Correct the hypermetropia, anything more than 2.5, treat the amblyopia before surgery. Now, infantile esotropia, again, like I said, please differentiate. Your newborn could have even a transient 6th cranial nerve paresis, which resolves with time. Give it some time, monitor it, because it could happen after a viral illness or spontaneously, and it resolves. You can have a child coming with an esotropia of 15 to 20 degrees with a normal extraocular movement, but see the papilledema here. Again, this is an esotropia which would need urgent neurology opinion. It is not an infantile esotropia. This is a child of about 2 years who came to us with a history of fever 1 month prior to reporting to us. Just to emphasize that other things need to be kept in mind. Going on to the next entity, acquired non-accommodative or basic esotropia. This is a comitant esotropia that's seen after 6 months of age. Distance near deviations are equal. There's no significant refractive error. Such children will need surgery to correct their esotropia. This is about 10.4% of all childhood esotropias. The AC/BI ratio is normal in these children. Coming to an important entity, acute acquired comitant esotropia. It's not necessary for all acute events to be emergencies or ominous, but we have to know when our evaluations and investigations have to be really done on a war footing. So acute esotropia can be because of breakage of fusion, as it can happen because of a patch after surgery, cataract surgery. It can be because of a decompensation of an esophoria or a hypermetropia. And you can also have it in high myopia. So acute onset esotropia, acute acquired comitant esotropia, an entity that is gaining a lot of traction these days. It is rare, but like I said, picking up these days, especially post-COVID. Now, if you have an acute esotropia without any apparent cause, like I mentioned, a myopia, hypermetropia, squint, occlusion, then we should be a little wary. If there is an association of headache, nystagmus, neurological associations, definitely we have to do an imaging and proceed ahead. But if because we could very well be dealing with an Arnold-Chiari malformation, a hydrocephalus, an astrocytoma, corpus callosum tumors, myasthenia gravis, like mentioned before, can fit into any bucket under any umbrella. Head trauma, increased intracranial pressure, ear infections can also cause this picture. So what would be the indications for imaging? According to certain studies, an ESO deviation which is larger at distance, a history of an acute esotropia in the past with a recurrence now, papilledema, of course, and older age at onset. However, this is something that I think most people do not practice, because in acute esotropia, if we have the first three factors, definitely imaging is indicated and a thorough CNS evaluation. AAC and mobile use, like I said, is really increasing. We are all, as strabismologists, seeing a lot of cases. According to the recommendations of the Indian Association of Pediatrics, less than 2 years, there should be no screen time. 2 to 5 years, there should be a screen time of maximum 1 hour. And if you do more than 4 hours a day for a minimum of 4 months, you could end up, besides having myopia, with an esotropia. And AC and mobile use, at least in practice, we don't see it reverting back once the mobile use is stopped. It generally tends to be there and it needs surgery. Myasthenia gravis, another non-accommodative squint, wherein you have a diplopia, you have a fluctuating ptosis. It's worse with fatigue. 60% present with ocular features and 15% have only ophthalmic signs even later on. So as you can see, this elderly lady here, which is quite all right with her glasses and prism, but otherwise you can see this esodiviation here with the retraction. You can see the abduction here. So remember myasthenia in any acute onset event, even in an acute onset esotropia. So next we go on to an important entity, divergence paralysis esotropia. So this is a professor who came to us with a diplopia more for distance than near. His reading was not really an issue, television, etc. were an issue. So when we examined him, we found a mild LR paresis in both the eyes, and we found a 14 PD basin for distance. For near, he didn't have very much, mild exophoria with a good compensation. This is a divergence paralysis esotropia. They respond well to prisms. Of course, he was hypertensive. We did get imaging done to rule out any compressive or infiltrative lesions. Cyclic esotropia, the next entity, it's very interesting, though the incidence is not very high, 1 to 3,000 to 1 to 5,000. And you can see this child here came to us on visit 1 like this. History was of a variable esotropia. Now, when we said variable, we ruled out an accommodative component, didn't find any. And then we saw her next day. We posted her for surgery, actually, and found that she was orthophoric. And we thought we had missed out an accommodative component because the father said she had a history of variability. So, and then we found out that we kept monitoring her and found that every 48 hours, her eyes would intern like this. This is a typical cyclic esotropia. These cases respond to the circadian rhythm and they do need surgery. Some of them could recur even post-surgery. So in a differential diagnosis, like I said, rule out accommodative factors, a recurrent benign sixth cranial nerve palsy by assessing the extraocular movements, and an acquired esotropia, of course. Spasm of near reflex. This is an extremely important entity because we do see it a lot, especially with high mobile use. It is said to be in those who are a little having some kind of psychological factors with extra stress, which can cause this. And the symptoms are intermittent, non-specific, blurring of vision, diplopia, and headache. Then you can see this young child here with orthophoria, and then you can see both the eyes are converging. So you have an increased accommodation with an increased convergence many times. This child also had a nystagmus. We got imaging done, which was normal. Then gave him lens rack exercises, put him on atropine to handle his spasm of near reflex. Microtropia, an important entity. Esodiviation, less than 10 prism diopters, not very obvious either to the patient or to the examiner. And important for us to know about this entity because very often this could be resulting in vision which is not optimal after cataract surgery or after any kind of interventions that we do. An isometropic amblyopia is one factor which can cause it. The 4PD base out test is considered positive. If it is positive, yes, if you see the refixation movement, but it may not be positive in all the cases. You can try to treat if the children are less than 6 years of age by occlusion and full correction of their hypermetropia. Sometimes you may have even myopic children with microtropia, but that's rare. Nystagmus blockage syndrome. This is again a form of infantile esotropia with a head turn, nystagmus on abduction. So the esotropia is mainly to control this nystagmus. We have to differentiate it from an abducens paralysis. and this tends to show more recurrence after surgery. So this was all about the comitant esotropias. Over the next few minutes, I'll just go through the incomitant esotropias. And an abducens nerve palsy is the most common isolated oculomotor palsy. Diplopia is the most common presentation. I'm sorry, my slides are just going on their own. And depending on the age group, we're looking at vascular causes, we're looking at viral or idiopathic causes, we're looking at neoplastic, CNS causes, trauma, all of that. And no age is exempt. We should remember a few things here. One is you could have a pituitary adenoma presenting like this. As we can see, the abduction limitation here as shown, corroborated by the Hess charting, and we find that the VP is showing lower amplitudes here. He did have a mild disc pallor also. So this is our pituitary tumor manifesting as a sixth cranial nerve palsy. IIH, this is a young lady who came to us with diplopia, headache, blurred vision. Typical features, the incidence is rising, said to be about 1 million per year. Check these after doing a BCVA. Look at the sixth cranial nerve paresis in both her eyes. Yeah, and we found a papilledema. So she had to be put on Dimox and she had a neurological assessment, and that's the way IIH is managed. Coming to the restrictive causes of esotropia. The first is the mechanical restrictive strabismus. Strabismus fixus, as you can see in this elderly lady here, where you can see a esotropia as well as a mild hypotropia here, and high myopia, congenital fibrosis, amyloidosis can be a rare cause of a mechanical restrictive strabismus. We have to do maximal surgeries, even disinnervations, to give the desired results in this kind of strabismus. Excessive MR resection is noted as one of the causes of restrictive strabismus. As you can see, this is a patient we'd operated for complaint of diplopia because he had intermittent exotropia, which was decompensating. You can see the abduction limitation here on day 1. Took him up, didn't really find that he had any slippage of the lateral rectus, which we expected. And you can see that after advancing the lateral rectus, he was better off with no diplopia. This is about a week after surgery. So this is another cause of an esotropia. Endocrine myopathy. Endocrine myopathy, as we know, the recti involvement are from inferior to medial to superior to lateral rectus. Important to remember this. And though it is mostly in a hyperthyroid patient, it could also be in a euthyroid or a hyperthyroid patient. And it's important to know that what we see in the lab test will not follow, the eyes will not follow the lab picture. That's important for us to kind of keep in mind. And surgery will be as per what we are seeing. Chronic progressive external ophthalmoplegia. This is an individual who came to us basically with a mild esotropia. You can see the frontalis overaction here. Over a period of about a decade and a half, he started developing a limitation of all extraocular movements. It's a mitochondrial myopathy, and basically prisms is the answer. Usually they don't have a diplopia. He had an esotropia. Usually you find that they have a symmetric kind of a worsening that happens. Surgery again is an answer if they are bothered by the eso or hypertropias. Congenital fibrosis of extraocular muscles is a rare condition, but we should all know about it as a restrictive esotropic entity. And here you can see the father and the child here. See the chin elevation here and the eyes in depression. So this is a congenital cranial disinnervation disorder with ptosis, restriction of all extraocular movements, and again, treat as per what we see. They generally do not have diplopia. You're doing it to alleviate the chin elevation most times, the surgery. Next is myositis. Myositis, as we can see in this individual here, this lady had this slight congestion here, and you can see this inflammation in the medial rectus muscle. She responded to steroids. So another form of restrictive esotropia. Coming to the last entity, that will be the secondary esodiviations, where we talk of sensory deprivation esotropia, wherein you have this child with a cataract, operated the cataract, then did the squint, and he's doing well with slightly suboptimal binocularity. So this is important. Relieve the cause for the sensory esotropia, and then go ahead and manage the squint. Next is consecutive esotropia, wherein this young child had a intermittent exotropia, went into mild ESO in the early postoperative phase, which actually increased in the late postoperative phase. This has to be treated with prisms and patching, and then after 6 months, maybe surgery if it does not respond. So this is a consecutive esotropia. So in summary, identify first if the esotropia is a true one or a pseudo-esotropia. If it is variable, it is likely accommodative with hypermetropia. Assess the distance and the near deviations. Are the extraocular movements full and free? If they are full and free, we are talking of a comitant squint. If it is incomitant, is it paretic? Is it restrictive? If it is acute, rule out any associated neurological associations, papilledema. Rule out excessive screen use. But before saying it's because of excessive screen use, we have to do due diligence. Myasthenia gravis, like I said, can present in various forms. Imaging and genetic testing whenever indicated. Thank you so much for a patient hearing. I'm sorry my slides kept doing their thing. Thank you very much.
Thank you so much. Thank you so much, Dr. Geeta, for delivering such a wonderful presentation on a very important topic for postgraduate students. Opening the discussion for the expert panel, Dr. Shubhangi Bhave, ma'am, please.
Geeta has practically covered all aspects of esotropia and covered it well. So I think nothing much to add to what she has said. But only thing is that since esotropia occurs at an age when it occurs at an earlier age, so early treatment is the crux of matter if we want to give them some semblance of or some sort of binocular vision. And also we have to impress on the patient that in a case of infantile esotropia, they might need 2 or 3 more surgeries in their lifetime.
Thank you, ma'am. Dr. Manjushri.
So yeah, I'd say the same that Dr. Geeta, you've covered a very extensive topic in a limited time. Maybe the only thing I would sort of have as a take home for the postgraduates is that when you see any patient with esotropia, I think it's really important to first try and understand whether it is a comitant or an incomitant esotropia. So that should be step number 1. And then step number 2 would be based on that, you narrow down your differential diagnosis of the list that comes under comitant and the list that comes under incomitant esotropias. Another important aspect, though we sometimes get a lot of late presentations, is their ability to have any good amount of stereopsis. So cases of infantile esotropia, once you've done at least 2 measurements which are consistent, I think these are the ones which need to be treated in good time, either by a surgery or initial Botox, as some people may prefer. So timely management is the other important thing as far as any esotropia or any esodiviation exo is concerned. But I think you've covered an extensive topic very well, so there's nothing more to add as such in anything. Thank you.
Thank you, ma'am. Thank you. Dr. Kavita, ma'am.
Thank you for that elaborate revision of the whole topic, ma'am. But sometimes what I'm feeling is we are missing on the high AC by A ratio.
Yes.
And the need for bifocal. Especially if the child is younger, it is very difficult to take the measurements.
Yes.
So in this scenarios, what I'm doing is counseling the parents. Since we are not able to take the measurements properly, we might need to change the glasses later.
Yes.
So that could be bifocal as well, because
Yes.
I have burnt my finger.
Yes.
And it happens so that the parents pick up that with the glasses for distance, the child is ortho, but for near, when his child is focusing at something near,
Yes.
this eye still squints. So we should be in a position to take that clue.
Yes.
And so now I have become very cautious about it, especially younger children. I think that is one thing.
Yeah.
And the rest other things, I think it's counseling, and then I take 3 measurements, ma'am. You said 2 measurements, but I take 3 measurements. Then if it's consistent with what I'm getting, then I go ahead with surgery. Thank you so much for this wonderful and elaborate
Thank you.
revision of the whole topic.
Thank you.
Thank you, ma'am. Dr. Simizaka, ma'am. You're muted.
Dr. Geeta, you have covered this topic so nicely. Nothing was left. Not much to add. Since I'm I'm there in a teaching hospital, repeatedly it has to be emphasized that fundus examination is in a small child, which is really, really difficult to do.
True.
And especially small retinoblastoma sitting at the macula. The first presentation and the commonest presentation is esotropia.
That's
So
right.
fundus examination is a must. Secondly, all these cases we have to go in for the eccentric fixation, isn't it?
Yes.
And another thing, because usually this is eccentric fixation is a thing which is at times missed out. Um, uh, Another thing which is basically whenever we are prescribing glasses, high power glasses to children, young children, for example, usually one thing which is about the parents going for the rimless glasses, the weight will be less. So it has to be emphasized that rimless glasses, it has to be a plastic glasses, and the centering. Doctor, when the patient was in the hospital, the squint was covered. When the child is wearing the glasses, the squint is not covered. And we find out this is a large frame or a very small frame. The centering is important. Last but not the least, the fit should be perfect. If it is pinching somewhere, the child is not going to use it. And for the children who are going to this school, the parents have to take time off, counsel the child, counsel the friends of the child, and last but not the least, the teacher should be taken into confidence and should be told that he or she should, they should ensure that the child is at least wearing the glasses. Ma'am, that is it's as otherwise you have this is basically for a postgraduate student. These are things which we emphasize when we are teaching the postgraduate students, but otherwise you have a very good revision of the topic.
Thank you.
Nicely covered. Every aspect was nicely covered.
Thank you
With
very
the
much.
time.
Thank you very
Thank you, ma'am.
Thank you very much, ma'am.
Thank you so much, panel. I would also like to highlight that we've got positive responses congratulating the speakers of the session in our YouTube live chat box today. And I also thank Dr. Siddharth for his prompt response in the live chat box with the audience. I think the audience have answered your questions. With this, we've come to an end of this wonderful informative session on strabismus as a part of the AIOS GuruSangam series. I extend my warm gratitude to the expert panelists for all the inputs and offering their valuable time for us towards this purpose. Thank you so much, doctors. I would also like to thank the heroes of the evening, the passionate gurus, Dr. Siddharth Agarwal, Dr. Annapurna Kumar, Dr. Snehal Thakre, and Dr. Geeta Srinivasan for taking out your time amidst your routine practice and busy schedule for helping and enriching the knowledge of the PGs countrywide. Thank you so much for your time. Thank you.
Thank you very much.
I hope this session has been educational and informative for all the attendees. All these sessions have been made accessible for all in our YouTube channel, AIOS channel. Please do check them out. Thank you, everybody. Have a very pleasant evening. Thank you so much.
Thank you.